Three, two, one. We are
Good
live
morning.
now.
Good morning, ladies and gentlemen. My name is Dr. Rajkiran and I am from Hyderabad. I welcome you all to this World Rheumatology Forum to be held today. And now, without waiting, I have a proud privilege to introduce you one of the greatest personality of Indian rheumatology. Actually, you don't need much of introduction for him. This man is one of the first rheumatologists, and he started rheumatology in India when none of us know what is rheumatology. Most of the doctors also do not know much about rheumatology, and he came to India and he started rheumatology, and he spread the awareness of rheumatology, and he taught many people what are the basics of rheumatoid arthritis and other connective tissue diseases. So without waiting much time, so I'll just give you a glimpse of this man. So he is awarded with Master of Aplar, Master of ACR, and he has got many distinguished awards. And his services are recognized by governments, state and central, and he has been awarded. So without any waiting, I will introduce to you none other than Professor K.M. Mahendranath sir. Mahendranath sir, over to you, sir. We would like to listen welcome address from you, sir.
Thank you, Rajkiran, for your kind introduction. Welcome you all to the first virtual summit meeting of the World Rheumatology Forum, which should have been happened last year physically. It didn't happen. Few years ago, myself, Dr. Dharmanand, Kaushik Chaudhary, and few other friends, we signed an MOU with the British Society of Rheumatology, and we were able to bring British Society of Rheumatology to India for the first time outside UK. Later, my other friends like Vinod Ravindran, Indrajit Agarwal, Ajit Nalwade, Bimlesh, and others expanded the scope of this forum, made it a World Rheumatology Forum, and has been successfully conducting every year great meetings with faculty around the world to enrich us, enlighten us, and teach us. And it has been a great success. I must say that they have worked very hard over the years. Until last March 29, 1 week before we postponed the meeting, and Ajit and the younger colleagues like Vinod mentioned had really put in hard work. It was heartbreaking to see that this meeting has been postponed. And anyhow, we decided this pandemic or the Chinese virus or coronavirus, whatever it is, it has caused immense damage to everyone in the world, in the humanity. But life must go on. And we decided to continue this in the virtual form. And today we have some of the brightest young minds in the country, whether it's Chanakya, Aarti, Meha, Balaji, anybody, Kavya, many of them, I know them. They are some of the brightest minds anywhere they can stand on any world platform today. And we also have the senior ones like Vikas Agarwal, who have their own expertise, who have reached the zenith. And we have a special guest, my old friend Chris Edwards. He's not new to India. He's an old friend of India. He's the chair and head of the Department of Rheumatology in Southampton University. He's a very well-known rheumatologist, very active rheumatologist in the European Ular Association, and also published huge number of articles and all. He's also involved in the great every year theme, 10 topics. And Chris Edwards is a brilliant speaker, a very fine orator. He has a very sharp analytical mind, and he will be talking about the disease progression, poor outcomes in patients with rheumatoid arthritis today to help us. And probably for uninitiated, you must also know that Chris Edwards is the son-in-law of Graham Hughes of Hughes syndrome. He's another greatest rheumatology personality, living personality on the earth, who is also a good friend of mine. And without any this thing, I welcome you all, and I hand over the mic to the moderator. Thank you.
Sir, you're muted. You have to unmute.
I'm sorry. Thank you very much for that kind introduction, Professor Mahendranath sir. And thank you informing us about Professor Edwards. We really don't know about his relation with Graham Hughes, and this is a new point for us to know today. but we are very much aware of this scientific work in rheumatology. And we will move forward to this case presentations. We have very interesting cases today. We have 3 interesting cases which have been being presented by Dr. Aarti from Delhi. So Dr. Aarti is a post-DM rheumatologist, and she is working as a consultant in Agrasen Hospital in Delhi. And we have Dr. Chanakya. Chanakya did his DM rheumatology from Nizam's Institute. Now he's in Bangalore, St. John's, and he is also recipient of APLAR fellowship. And we have one of the brightest and young rheumatologists from South India, Dr. C. Balaji. So Balaji did his rheumatology DM from Chennai MMC, and now Balaji is working in Ramchandra Medical College. So now we'll start the proceedings. So all 3 speakers are requested to present their cases one after the other. And once we finish off these 3 case presentations, we will have a discussion. And I'll request the audience, please put your questions in the chat box once all the 3 cases are over. So we will open up the chat box and we'll look at the questions, and I will moderate the questions. So I will try to answer most of the questions which have been put by you. And we'll see that this particular session will be very informative and will be useful to your clinical practice. Over to you, Dr. Aarti.
Thank you so much, Dr. Rajkiran. So we will be discussing about an interesting case of rheumatoid arthritis. Definitely not an unusual one, but definitely a challenging one in daily clinical practice. So there came a female, 52-year-old female with no prior history of comorbidity. She presented to me with a history of inflammatory polyarthritis for 4 to 5 years, with a short duration history of around 1 month of blackening of left great toe, along with the ulceration over the same toe, and along with the ulceration over the left lateral malleolus and the right heel. She also complained of low-grade fever for the 10 days. All her peripheral pulses were palpable, they were regular, there was no radial or radiofemoral delay, and all her BP was normal in all the 4 limbs. The only thing which was weak was dorsalis pedis, and probably this is because of the overlying edema. When we talk about her musculoskeletal examination, she had active synovitis in her bilateral elbows, wrist, and metacarpophalangeal joints. And in the chest examination, there were increpts in the right infrascapular, interscapular, and the infraclavicular areas. There was no significant history of sensory impairment, paresthesias, any palpable purpuras, dryness of eyes or mouth, recurrent oral ulceration, photosensitivity, abortions, Raynaud's, or claudication. Next slide, please. So this is the image of a patient where you can easily appreciate in the image 1, there is a lot of ulceration along with the cutaneous gangrene over to the left great toe. You can also see gangrenous changes, the cutaneous gangrene over the right second toe. And in the second picture, the left great toe is more visible, where you can see certain of the infective areas as well in the ulceration part. In the third image, this is of the left lateral malleolus, where you can appreciate the ulcers clearly. So this is the picture of the patient where there are multiple things in this. Next slide. So this is an X-ray of the patient where you can see that there is a radiocarpal narrowing, there is carpal crowding, there is a lot of juxta-articular osteopenia, and there are multiple erosions in the metacarpophalangeal joints as well. So to summarize, this is a 52-year-old female with a background history of inflammatory polyarthritis, along with a history of gangrene and the cutaneous ulcers. So the possibilities which came to our mind were rheumatoid arthritis with the secondary vasculitis because of the history and the X-ray images. Second we thought of is antiphospholipid antibody syndrome, which can be primary or secondary to an other underlying rheumatic disease. And third is primary systemic vasculitis. Next slide. So we went over to some investigations where we found the high TLC count, which was around 29,000. ESR and CRP, quantitative CRP were elevated. It was 141 and 100. Rheumatoid factor was positive, though I don't have the value for the rheumatoid factor, but the anti-CCP was around 993. To our surprise, anti-HCV came as reactive and HCV RNA was undetectable in this patient. All other PT and APTT was normal. Serum globulin was on the higher side, which was 4.3. HbA1c was normal. Urine routine and microscopy showed 12 to 15 pulses with no albumin or the cast. Urine culture and sensitivity showed contamination. The next slide. In the background of anti-HCV being positive, we carried out serum cryoglobulin as well, which came out to be negative. ANA came out by immunofluorescence was 4 positive homogeneous in the titers of 1:100. C4 was low. In ENA, there was anti-SCL70 being positive, and anti-MPO and TPR3 by ELISA was negative. We performed the arterial Doppler of the lower limbs and the ultrasound abdomen as well in this patient. And we found there was altered triphasic wave pattern in the patient of the bilateral lower limb along with the marked reduced velocity on both the sides. We performed the skin biopsy from the ulcer edge and we found the neutrophilic vasculitis with a lot of fibrinoid necrosis being going on. So, if we talk about the history and the examination along with the investigations, were we dealing with the case of rheumatoid arthritis or a lupus because the ANA was 4 positive homogeneous with the secondary vasculitis with hepatitis C, or is it hepatitis C with the cryoglobulinic syndrome? So, in fact, let's see some of the literature, what the literature has to say about these syndromes or the rheumatoid arthritis with hepatitis C. The next slide. So when we talk about rheumatoid arthritis, then these patients who have this secondary vasculitis because of the rheumatoid arthritis, they have anti-CCP being positive in 90% of the cases with the high titers. And lack of antibody confers the negative predictive value for rheumatoid arthritis-related vasculitis. So similarly, this is our case. ANCA can come positive by immunofluorescence, and this is usually the atypical ANCA, which comes positive in around 48% of the cases. While if you do ANCA by ELISA, it should come out to be normal or negative. Complements definitely goes on to the lower side, especially the C4. And when we talk about the definitive diagnosis of rheumatoid vasculitis, it has to be done by the skin biopsy if possible, which has the highest yield of around 75%. In case we are unable to take the skin biopsy for some reason, we can go for the sural nerve or the peroneal nerve biopsy as well, which has a yield slightly lower than the skin biopsy, which is around 50%. Next slide. So this is the slide showing the neutrophilic infiltration of the vessel wall along with the fibrinoid necrosis. As we saw in our case, there is a lot of necrosis and leukocytoclasis and disruption of internal and the elastic lamina. Next slide. Next slide. So what do we say about, the previous one. So what do we say about the false positive HCV in rheumatoid arthritis? Previous belief says that high titers of rheumatoid factor being positive can lead to the false positive anti-HCV. So is it true? So we reviewed certain literature and the papers about the false positive anti-HCV in the patients of rheumatoid arthritis with the high titers of rheumatoid factors. Next slide. So after reviewing the literature, we found that wherever the previous thought was that these can be false positive doesn't stand true nowadays, and it says that anti-HCV can come positive, and it is not necessary it has to be false one. It can be true positive anti-HCV, and we need to evaluate the patient accordingly. The next slide. This is another study which stated that high titers of serum rheumatoid factor are not responsible for the false positive results of the anti-HCV IgM test. The next slide. So let's move over to the rheumatic manifestations of the HCV. So there are certain strength of associations which goes between the HCV and the diseases. There are high, medium, and the low strength of association. If we talk about HCV syndrome, where we have HCV RNA positive anti-HCV being there, then we see that there is a high strength of association with the mixed cryoglobulinemia, medium with the Sika syndrome, and low with the Sjogren one. Similarly, in our patient, we carried out the cryoglobulin test, which came out to be negative. The Sika symptoms were not there. Next slide. So HCV-related infection has these syndrome, the most common being the mixed cryoglobulinemia syndrome. But in this syndrome, we have HCV being positive. We have rheumatoid factor positivity, but anti-CCP has to come negative, which was not there in our case. Similarly, if we think that this is HCV-related arthritis, then it has to be a non-erosive one. Again, this is not in our case. Then it has to be oligoarthritis. R had a polyarthritis. HCV should be positive, which can be negative, and anti-HCV can be positive. Rheumatoid factor can be positive or negative, which was there, and anti-HCCP has to be negative. So the two common strengths of association of the rheumatic diseases, which we see in the HCV infection, being the mixed cryoglobulinemia and HCV-related arthritis, has been ruled out in our case based upon anti-CCP positivity and the erosive polyarthritis, which we have seen in our case. So definitely, now we move over to the another one, which is rheumatoid arthritis, which is an overlap of infection where you see HCV as a co-infection over the rheumatoid arthritis, which appears to be our case. In this, we have symmetric polyarthritis with erosions, with HCV being negative and rheumatoid factor positive, anti-CCP being positive, and cryo can be negative. Next slide. So how do we go about in such patients? When we have chronic arthritis, we need to see whether the patients had this as a comorbidity or it is HCV-related polyarthritis or oligoarthritis or mixed cryoglobulinemia syndrome. Once it is a mixed cryoglobulinemia syndrome, on the basis of non-erosive oligoarthritis, cryoglobulin being present and low C4 with anti-CCP being absent, rituximab is one very good drug which has shown wonderful results in the patients with the mixed cryoglobulinemia syndrome. And if we talk about HCV-related oligo or polyarthritis, then HCQ, low steroid, and rituximab along with the treatment of underlying hepatitis C. And when we see it as a comorbidity with the rheumatoid arthritis and HCV infection, then HCQ, anti-TNF, anti-CD20, and low-dose steroids and DMARDs can be used. This is our case. The next slide. Next slide. So to end, we have this case where in this patient we can have multiple autoantibody being positive, and this helps in making a good clinical diagnosis. Thank you. So in our case, we have a treatment of rheumatoid vasculitis with hepatitis C. You can switch over to the methotrexate or leflunomide. But yes, we have to see the underlying liver pathology in this case. And cryoglobulin testing, even if it comes out to be positive, doesn't always denote a syndrome, because cryoglobulin can come positive in around 50% of the patient of hepatitis C. Similarly, when multiple autoantibodies are coming positive, like ANCA, ANA, anti-SCL70, then it shows that there is an underlying anti-SCV or the hepatitis C being reactive in these patients. So we have to focus on some things to differentiate between the rheumatoid arthritis vasculitis when we have comorbid hepatitis C, and anti-CCP erosions and polyarthritis definitely helps us in making and differentiating it from the HCV related arthritis. Thank you so much.
Just a minute. Audience are requested to please post their questions in the chat box. Yeah, over to you, Chanakya.
Good morning, everyone. I'm going to present another difficult to treat case of rheumatoid arthritis. This is the story of a 62-year-old man who is a physician. He presented to us for the first time in 2004. You can see his background comorbidities on the slide. So he presented to us with symmetric inflammatory polyarthritis and was diagnosed to have seropositive rheumatoid arthritis with very high titer rheumatoid factor and anti-CCP titers. He was, back in 2004, he was initiated on treatment with methotrexate, sulfasalazine, and hydroxychloroquine. He used to take intermittently steroids whenever there was any flare in the arthritis. So from 2004 onwards, his range of his methotrexate were being titrated to receive as high as 25 mg, and which was started at 15 milligrams. Next slide, please. His clinical course was uneventful until 2012, when he met with a road traffic accident and sustained rib fractures, when for the first time a CT of his chest was done to evaluate for the rib fractures. And it was noted that some basal fibrosis was noted on the CT scan, which was consistent with the NSIP, which was very early. However, till now, he was asymptomatic for any of his pulmonary symptoms. And we just noted this finding. In the next few weeks, he recovered completely and from his rib fractures, and he got back to work. Next slide, please. Early in 2013, in spite of being on methotrexate and sulfasalazine and hydroxychloroquine, his arthritis flared, and he was started on anti-IL-6 molecule injection tocilizumab monthly infusions. So just after 4 months of starting tocilizumab, he presented to us with acute onset dyspnea and hypoxemia, We suspected infection as we looked at his HRCT images, which were showing new multiple opacities. So an infection workup was carried out to prove for any viral, bacterial or mycobacterial infections. However, all of which was negative. So considering this, that this could be a rheumatoid lung, we gave him high dose steroids, and his hypoxemia resolved. And further, steroids were slowly tapered. A repeat HRCT was done, which showed that these shadows resolved, but a background basal fibrosis, that is the NSIP, which was detected early in 2012, was persisting. Next, please, so that the slides are visible. Okay. So with this acute presentation of dyspnea, he did not want to continue methotrexate anymore due to the fear of worsening ILD. And we had to switch him to leflunomide 10 mg at that time from methotrexate. Tocilizumab and sulfasalazine were continued. Hydroxychloroquine was discontinued due to macular thinning. You can look at the HRCT images, and his FVC in June 2013 was 2.53 liters. Next slide, please. For next 2 years, he continued tocilizumab and sulfasalazine and leflunomide when his disease went into remission, and we discontinued tocilizumab. 2 years he was doing well on only DMARDs, and when in January 2017 he developed symptoms of peripheral sensory neuropathy. He himself withdrew leflunomide, attributing these symptoms to leflunomide, and then he restarted methotrexate because his arthritis was pretty stable at that time. However, it was noted that his neuropathy symptoms had improved. 2 months after this change, that is with discontinuing leflunomide and restarting methotrexate, he developed new rheumatoid nodules, and his arthritis started flaring up again. You can look at the CT films here. So the CT films are from 2015 when tocilizumab was discontinued. This showed progression of the previous fibrotic NSIP, and the FVC showed a mild decline from 2.53 to 2.45. However, after 2 years, that is in January 2017, when this arthritis was flaring and methotrexate was started, we had to give him a new biologic. So he at that time, tofacitinib was available in the armamentarium. So because it was his own personal choice not to take an injectable biologic at that time, and he opted for tofacitinib, although we considered giving him rituximab in view of arthritis, seropositive rheumatoid arthritis, and progressive ILD. His FVC in 2017 was 2.69 liter. Next slide, please. So 2 years on tofacitinib, from 2017 to 2019, he did perfectly well with respect to his arthritis. In 2019, he presented again to us with acute dyspnea. His HRCT chest showed new pulmonary shadows. Next, please, to display the images. You can look at the CT films, which shows new pulmonary shadows. Infective workup, again, which was performed at this time, was negative for any mycobacterial, bacterial, or viral pneumonias. A bronchoscopy was undertaken to identify the cause for this worsening. There was evidence of probable DAH because hemosiderin-laden macrophages were positive. And on this account, please note that there was no hemoptysis that this patient complained of. However, there was a mild drop in hemoglobin of 2 grams. So with this evidence of probable DAH, we worked up for any alternative causes like any primary lung vasculitis or ANCA vasculitis. So his ANA, ANCA, complement levels, urine routine, and creatinine were all within normal range. So with infections being negative, we treated him with high-dose steroids and cyclophosphamide, considering this DAH as pulmonary vasculitis, with cyclophosphamide 6 monthly infusions. With this, he improved significantly and he returned back to work. Next slide, please. Within a month of completing cyclophosphamide infusions, because he was off his DMARDs and tofacitinib, his arthritis went into a polyarticular flare. So we restarted immediately leflunomide along with low-dose prednisolone, but arthritis was continuing to flare. So because he did really well on tofacitinib, the previous slide, please. Because he did really well on tofacitinib, so he again wanted to go back to tofacitinib, even though rituximab was again considered at this point of time because of progressive ILD. So in October 2019, we gave him tofacitinib 5 mg BD again, his FVC showed a further decline to 2.11 liter. Next slide, please. 2 months after this, again, he presented to us again with acute dyspnea. This time there was a significant history of travel. He had taken a family vacation to northeastern India and returned back with this acute dyspnea. We suspected an acute infective exacerbation of ILD. So we treated him with empirical antibiotics. However, there was no organism identified. High-dose steroids was also used considering his background 2 presentations in the past of similar type of presentations with which he improved. We also considered PCP pneumonia. However, we could not prove it microbiologically. His FVC declined further to 2.07 liter at this time. So mind you, this is December 2019 when coronavirus cases were being reported early in China. At that time, we were not aware of this infection in India at that time. So he was vaccinated with influenza pneumococcal vaccine as per the recommendations. Next slide, please. So his arthritis and lung symptoms in the past, in the current COVID pandemic have been stable while he was on leflunomide 10 mg per day, tofacitinib 5 mg BD and prednisolone 5 mg per day. Next slide, please. So his diagnosis was active seropositive rheumatoid arthritis with nodules and progressive fibrotic NSIP. Next slide, please. So if we look at, next slide, please. If we look at the literature for treatment of rheumatoid arthritis related ILD, most of it was extrapolated from the trials of systemic sclerosis ILD. But if we specifically looked at which biologic was useful with rheumatoid arthritis ILD, I came across this review, recent review. If you look at the article types, most of them are retrospective series or case reports or series or one observational study. If you look at the number of patients, it's about 201. More than 80% of patients showed either stability or improvement in the lung function when treated with rituximab. Next slide, please. So the relevance of this case being both arthritis and ILD have been particularly challenging, with that both of them flaring as soon as any treatment was modified slightly or withdrawn. Although tofacitinib was doing good for his joint disease, it seemed that the pulmonary disease has been slowly progressive. In this setting, rheumatoid arthritis, as I pointed out, has got a better evidence.
Conclude soon?
Yes, sir. So this is the last slide. So the DAH was a strange event in this patient. Could it have been infection triggered? We did not have any microbiological evidence. However, fingers crossed that it doesn't happen again. But if it happens, then rituximab is the obvious choice for us in this patient. Thank you.
Good morning. I'm Dr. C. Balaji. This is my case today. This patient is a 58-year-old female. She's a seropositive rheumatoid arthritis with high titer RF anti-CCP positivity. She had a past history of diabetes and pulmonary tuberculosis at 33 years of age. Initially, she was treated by a rheumatologist with triple DMARD therapy, but she developed drug intolerance and hence she stopped the treatment by herself. Then she resorted to alternative Siddha treatment, and she was also on prednisolone 5 mg and hydroxychloroquine 200 mg OD for about 8 years. Next slide. While on this treatment of Siddha and steroid and hydroxychloroquine, patient had developed left hip pain and she consulted an orthopedician who diagnosed her to have bilateral hip AVN, and she underwent left total hip replacement. The steroids were stopped, but she continued to take hydroxychloroquine 200 mg. In Feb 2018, this was the first time I saw her. She presented to OPD with polyarticular flare involving the MCP, PIP, wrist and knee joints. She also had left elbow FFT. Her labs, her acute phase reactants were elevated, and her simplified disease activity index showed high disease activity. I did an OCT because she was on HCQS for about 8 years, which showed macular thinning. Next slide. So I discussed the option of biologic DMARDs versus conventional synthetic DMARDs with this patient. Patient was not willing for biologic DMARDs due to issues with affordability. Hence, I started her on methotrexate, leflunomide, and folic acid with naproxen 500 mg BD. Next slide. 1 month after starting treatment, patient presented with severe GI intolerance, uneasiness, and mood disturbances, which was probably due to methotrexate intolerance. She had these similar symptoms when these DMARDs were started in 2019, so the patient was not keen on continuing DMARD therapy. So I had to stop methotrexate and I advised her to continue leflunomide. Sulfasalazine was added and I uptitrated the DMARD dose to 20 mg leflunomide, sulfasalazine 1 gram, and naproxen. We continued this treatment for about 3 to 4 months, but there was no response or very minimal response with the S-type. Next slide. At this juncture, I discussed with the patient the option of biologics. In view of seropositivity and past history of tuberculosis, we gave her rituximab 1 gram. Her serum IgG levels were within normal limits prior to rituximab infusion. During the course of rituximab treatment, by about 3rd month of rituximab, all the parameters of the patient improved. The ESR, CRP, tender joint count, swollen joint count, and the STI. She achieved low disease activity by 3rd month of rituximab therapy. Next slide. But what happened was 3 months after rituximab, she presented to casualty with fever, abdominal pain, and dysuria. Her CT-KUB was suggestive of acute pyelonephritis. So we gave her antibiotics for 2 weeks and then she recovered. Then after this episode of pyelonephritis, she lost to follow-up for 5 months. And then her joint symptoms were better during this period. But again, she presented with a polyarticular flare. Next slide. At this juncture, patient was not keen on continuing rituximab in view of the pyelonephritis that she had recently. So I had discussed with her the option of anti-TNF versus tocilizumab versus tofacitinib. But patient had severe financial constraints. So we decided to start her on biosimilar anti-TNF because that was the only drug that she could afford within her budget. So I started her on etanercept 25 mg weekly once with sulfasalazine 1 gram. Patient responded very well to etanercept and achieved ACR 70 by 12 weeks. Next slide. So I continued etanercept for about 8 months. By Feb 2020, patient was asymptomatic. By then, I had de-escalated etanercept to once in 10 days and continued sulfasalazine. He achieved remission by Feb 2020. And then the lockdown happened. Patient stopped etanercept for 4 months, during which she was asymptomatic. She came on teleconsultation, and at that time she had mild symptoms and mild elevation of ESR CRP. I advised her to restart etanercept weekly once, but again, due to the financial issue, she has been by herself taking once in 15 days for the past 3 months, but now she's been doing well. Next slide. Now, the patient's question to me is, when are you stopping the injections? The options for me are very limited. Because she's not responding to the conventional DMARDs and has been having side effects with every drug that has been started for her. Now, I have to convince her to either continue de-escalated etanercept therapy or try igrutimab plus sulfasalazine. I'm not sure if igrutimab plus sulfasalazine is going to work for her because the leflunomide sulfasalazine combination also did not work. Or another option is to try generic tofacitinib, which is now available in our country. So these are the options left for me now. Next slide. The therapeutic decision that a rheumatologist makes every day is not only balanced between the efficacy and the adverse effects of the drug, but in India, we also have the problem of affordability. So every patient, we also have to look into this issue while prescribing the biologic DMARDs. Next slide. So balancing this is very difficult. In our country, there is a study from, next slide. There's a study from Shenoy et al. Center where they have tried very low dose rituximab, 100 milligrams in active RA despite combination DMARD therapy and have shown good results in this study. Next slide. So why is this case relevant? There were multiple therapeutic challenges with this patient. With steroids, patient had AV and hip and diabetes. She was intolerant to methotrexate. Leflunomide, sulfasalazine were not enough. She was not having good response to these drugs. HCQS was associated with macular thinning. With rituximab, she developed pyelonephritis. In cases where there are risk factors like diabetes, past history of tuberculosis, with this case also had an episode of pyelonephritis, steroid dependence, we can try low-dose biologics upfront. Usually we discuss about tapering biologics, but even starting the patient on upfront low-dose biologics could work in Indian scenario where patients are not affordable. Plus, the additional risk factors where the chances of infection are high, this choice of using upfront low-dose biologics in our population could work. This is the reason why I wanted to present this case today. Thank you for the opportunity.
Thank you. Thank you very much, all the presenters. It was it was a wonderful cases, and most of the cases actually depict the real world scenarios. What we see every day are these cases of rheumatoid arthritis with a coexisting hepatitis C, and Chanakya's case of RA with ILD and difficulties in treating when you have an ILD in a patient with RA to control the inflammatory arthritis. And the third one, Balaji's case, where you give one biologic and patient had responded to that, but again they had developed some adverse effects which they believe or could be due to that biologic, and switching to other biologic they do well, but when to stop these drugs, when to stop these expensive medications in like in our country, like most of the patients, they have to bear the cost from their pocket, and definitely at some point they will ask us when to stop these medications, especially the expensive ones. So we will with this we will go to the questions. I'm seeing a good number of questions in this chat box, so we will go case by case. So there is Bimlesh is asking, like when we do hepatitis B antibodies are positive, do we also need to do HCV RNA before initiating therapy for vasculitis? Yes, Bimlesh, we need to do HCV RNA, and if Hep C antibodies are positive, it's better. We most of us, we also involve gastroenterologists. We need to have a dialogue with them. We need to look at HCV RNAs. And as Aarti was telling, when you have an HCV positive in a patient with rheumatoid arthritis, we also need to look for mixed cryoglobulins, which can quite often seen in these group of patients. And Bimlesh has also asked, can we give sofosbuvir and rituximab together? And I think there are certain case reports where they have used these combinations, or else it's most often rituximab, ribavirin, and interferons are given. So I think we can use this. We have to use this combination of antivirals and immunosuppressants when we have both active HCV as well as like vasculitis, which is occurring because of HCV. And Dr. Ankul Dalal, he is asking, do we need to consider doing viral screening like HIV, HBsAg, and HCV in each suspected cases of rheumatic diseases, like prior starting DMARDs? Yes, I think the recommendations are like that. Before starting methotrexate or any DMARDs, we need to do viral screening. But I think in clinical practice, some centers they do and some centers they don't do. And most often we immediately do when we find an altered liver enzymes or elevated liver enzymes. But I think it should be a good practice to see. I think in this way we can identify the cases of hepatitis C induced arthritis, and we can remove the confusion of early arthritis, early rheumatoid arthritis with high rheumatoid factor titers and anti-CCP negative and Hep C related arthritis. And there are also some questions, but these are related to the second case. And we have our guest like Professor Edwards. So I would like to discuss with, I would like to ask this question to Professor Chris Edwards, like how frequently you come across hepatitis C infection with rheumatoid arthritis in your country?
Thanks very much for the question. So in a UK setting, I think it's less common. And so I think you'll have perhaps more experience than I do in a UK setting, and it will vary depending on areas of the UK. I thought all the cases were fantastic, and it was very interesting listening to the first case. The other things I wondered, I can't remember if from the case history, the autoantibodies around the specificity of the ANA came out, because although the pattern was homogeneous, I just wondered whether there were also anti-Rho antibodies as well, which you might expect to be speckled. Because whenever I see that combination of low C4, even in the context of hepatitis C and rheumatoid, you're also thinking, I wonder if there's some Sjögren syndrome that's driving this process that's present as well. And I agree completely with your comment that it's really important to involve the hepatologist, isn't it? You know, in these situations, I want the hepatologist to help me to treat the hepatitis C. And then that clears the way for the rheumatologist to immunosuppress, because the pictures of that poor lady's feet and toes and how unpleasant that must be for her to lose, digits. It's important we treat as aggressively as possible.
Dr. Aarti, like Professor Edwards are asking, like, what was the pattern of ANA? You said it's homogeneous pattern. Any further analysis has been done to look into the subtype of autoantibodies or classify it as a Sjogren's, secondary Sjogren's?
Sir, if we talk about clinical history, initially there was no history of dry eyes or dry mouth, but still based upon ANA being positive and 4 positive homogeneous, we went out for the extractable nuclear antigen, where there was only anti-HCl 70 positive, anti-Rho and anti-LA was negative.
So I missed that, so thank you.
Based upon that DNA, we ruled out, and upon the history, we ruled out that there's no Sjogren in that. And anti-HCl 70 can come positive because of the HCV-related stimulation of the B cell, which can lead to the polyclonal autoantibody formation. So we have multiple autoantibody in this patient based upon the HCV positivity.
Okay, thank you very much. And as you say, when people have rheumatoid factor as well, often you get false positives, don't you? So it becomes difficult because you end up with everything positive if you're not careful. And
exactly, sir. Exactly, sir. That is why I insisted on one point, that being anti-CCP in such a high titer, this prompted us to make a diagnosis of rheumatoid arthritis with vasculitis rather than it is being related to the HCV. We don't get anti-CCP positivity in the patients of HCV positivity. It is only in the rheumatoid arthritis related vasculitis where you see such high titers of anti-CCP positive. That is the point which differentiates HCV related vasculitis from the rheumatoid arthritis related vasculitis, especially in our cases where we these combinations commonly in our clinical practice.
Very good, thank you.
Yeah. So what do you say, Professor Edwards? Like Aarti says, like we can get a lot of antibodies if someone has HCV infection, because HCV, I think via its activation through TLR7, it can generate more of these RNA antibodies and other antibodies and high titers of rheumatoid factors, IgM rheumatoid factors. But again, to generate an anti-CCP, we need to have a citrullation process to be occurring. And I think the citrullation process doesn't occur much with HCV infections. And so that's how it's again a different thing. So that's how if the patient has an high levels of anti-CCP, and it has to be the rheumatoid process might have kicked in, like rather than the HCV causing antibody generation.
Yeah, I agree with you completely. I suppose it's also, and as clinicians, we all know this, don't we? You know, when there's a lot of rheumatoid factor about, sometimes the immunology tests become falsely positive. And also immunology tests are not as reliable as something like a full blood count. And so what's vital is what the clinical situation is rather than just the specific antibody. So I think that's important as well. I'd never rely completely on the immunology test or a single immunology test. It's also taken in the round with the patient's situation as well.
And therapy-wise, if you have a coexistent rheumatoid arthritis and HCV antibody positive together, Dr. Aarti has clearly mentioned that if HCV is positive, we need to further evaluate. We need to do HCV RNAs. And Professor Christopher also told us, like, it's better we involve a hepatologist at this time, and we have a dialogue with them. And the treatment, the moving forward purely depends upon the type of clinical manifestations rather than type of antibodies what they have. This is what Professor Christopher says. If the patients have a mild symptoms like arthritis and skin manifestations, you can manage with simple drugs like methotrexate and other like simple drugs. Like if you have a complicated features like vasculitis involving these digital gangrene, which if they're attributed to cryoglobulins, maybe we might have to increase our immunosuppression by giving cyclophosphamide or rituximab. So similarly, if we have a renal manifestation, again, we might have sometime should get a plasmapheresis done and involving nephrologist. So depending upon the type of manifestations, we need to decide our therapy. So with this, we will move to discussion of our next case. And the next case is a Chanakya's case, which is about presence of interstitial lung disease in rheumatoid arthritis. So this case, Chanakya has told how difficult it is to manage these cases, especially when the patient doesn't listen to you. And right from beginning, he has a gut feeling that the rituximab, with the available data, the rituximab will help him in improving his arthritis and as well as stabilizing his interstitial lung disease. But again, we have a patient, and in this time of shared decision making, we discuss with the patients openly, and we have a patient who doesn't agree to take rituximab for whatsoever reasons it is, and you have tried all different drugs. So we have tried tocilizumab, we have tried tofacitinib, and though there are some case series where when tocilizumab is given to rheumatoid arthritis, the ILD was more or less stable, and there are also contradictory to that, we have certain case reports which also see that ILD has worsened a little bit on tofacitinib. So lots of mixture of data is available. And going further into the discussion of this case, Professor Malviya had given his comments stating that acute presentation with dyspnea is not the presentation of RALD. So Professor Malviya clearly states this point, and he emphasizes mentioning that if you come across a dyspnea which is of an acute presentation, don't think of RALD. So with the setting, with the background of methotrexate, it definitely could be a methotrexate hypersensitivity. In that context, you discontinue methotrexate, initiate steroids. It should help the patient. So he clearly says in his bold words that MTX does not cause ILD. I think in last year EULAR, I think Professor Chris, like the 10-year data of methotrexate has been presented from BSR. I think, I'm not very sure, but they tell that they have not found much of increase in incidence of ILD in patients who have used methotrexate. Your comments on this, Professor Christopher?
Okay, so this is a very common question, isn't it? And it's a fear amongst all us as physicians. So, of course, we know about pneumonitis, which tends to occur early on in disease with methotrexate. But I also agree that I don't think there's an association between methotrexate and interstitial lung disease in the doses that are used by rheumatologists. So maybe with cancer doses, maybe it's a different thing. The data you were talking about, I think, is the data that Patrick Kiley was involved with at St George's Hospital from the early rheumatoid arthritis network studies, where they followed a large number of people and see no association between interstitial lung disease and methotrexate. And the only other tip I have from my respiratory physicians is we heard about the the FVC for this patient, and it remained above 2, I think, for most of the time. So the chest physicians will say they have no fear in starting methotrexate in someone with interstitial lung disease, as long as the FVC is greater than 1 litre. If it falls to greater than 1 litre and then someone gets pneumonitis, then they have very little reserve and the outcome can be very poor. But if they have enough FCV, even if they got pneumonitis on top of the interstitial lung disease, they should be safe. It could be stopped and they could be treated with steroids. So I agree. Methotrexate, I don't think causes interstitial lung disease. I think it might treat it sometimes.
Yeah. So another thing Professor Malviya also tells us, being a male, elderly, smoker, and high titers of ACPA. So these are the risk factors for someone to develop ILD in patients with rheumatoid arthritis. You need to watch for these things. And other thing Professor Malviya was also mentioning is leflunomide itself can also be toxic to lung. So you have to be careful using leflunomide. Again, the recent data says leflunomide is not that toxic, and the previous data says the leflunomide is toxic to lung. So what's your take on leflunomide and lung, Professor Christopher?
Thank you. I have much less experience of that. I think, once again, I agree with the comments made that I think there are some associations sometimes with having lung problems. I don't know how definite they are. In the same way that some of the biological therapies will occasionally give some sort of hypersensitivity, pneumonitis, inflammatory changes with the lung as well, which you see very, very rarely. So it's also worth, thinking of all these possibilities. But the biggest concern is with methotrexate, isn't it? And I think we can remove some of that concern. I think the data is there to support us.
And we have actually 2 types of patterns commonly we observe in patients with rheumatoid arthritis, the lung patterns. Most commonly we come across UIP pattern, which is quite common and which is much resistant to treatment, and sometimes it might progress. And we have an NSIP pattern, which is not that common in RA, but we might find in other CTDs. And they say NSIP pattern might respond very well to all your therapies. And this case of Chanakya had, to begin with, it has an NSIP pattern. It has evolved into fibrotic pattern despite of therapy. So what's your take on this, like UIP patterns and NSIP pattern? And there's also mention about hypothesis, like when you have an UIP pattern, most often the disease might have started in the lungs. And when you have an NSIP pattern, the disease might have started in the joints and it might have reached in the lungs. So the treatment, like what's your like experience like in these cases? So like does both of these groups do badly, or definitely it is NSIP, they might get stabilized with therapy, and UIP, they might have a progressive downhill course?
I suppose for me, I take in my mind what I think is a more clinical approach. So the respiratory physicians are very interested in the patterns and the NSIP and the UIP. For me, when I'm looking at the scan, what I want to know is how much inflammation, how much is ground glass, and how much is fibrotic. And if there's ground glass, that should be reversible and that should be treatable. And if there's fibrotic change, that's the best you're going to achieve, is to stabilize the situation, because it's a scar and you can't make it go away. So I have to say, I focus more on how much activity, how much inflammation and ground glass, and how much fibrosis, rather than defining the specific pattern, which I've never found really useful in terms of making clinical decisions.
Yeah. So we are running short of time, and further questions can be answered regarding this in the chat box. And we'll move on to the last case, and a couple of questions in this last case. One is regarding methotrexate intolerance, like Professor Malviya suggested, like he's quite a favorite of giving coffee to the patients. And there is also pathophysiology which explains like how coffee can have its inhibitory effects on adenosine and other things. So if you can give an extra cups of coffee to the patients who are intolerant to methotrexate, so it would help. What's your take like dealing with methotrexate intolerance, Professor Christopher?
Thank you. So I haven't come across the coffee solutions in the past, but I'm interested to read more about that. So I'm going to go away and educate myself now. So I think there are a number of different things we try. We increase the amount of folic acid we give, don't we? Rather than just giving it 1 day per week, we start to give it more regularly. We give subcutaneous instead of giving oral to try and help with tolerance. We try to reassure the patient, because there's a lot of bad information on the internet that frightens patients about methotrexate. So good, reliable education can help. And sometimes to gain patients' confidence, I'll start with a very, very low dose, even 2.5 milligrams per week, and then build it up, because that gains their confidence. Because to start at 15 for some people is too frightening, even though as clinicians we may be happy with that.
And another question, leflunomide-induced neuropathy, how common it is? And I think leflunomide, in the loading doses of leflunomide, it was quite common. I think recent past leflunomide-induced neuropathy is not that much common, but still now and then the case reports are heard of leflunomide-induced neuropathy. And the other thing is, which biologics are safer in RA with ILD? And I think anti-TNF definitely has there are a lot of case reports saying that infliximab and adalimumab had worsened ILD, and the new onset of ILD has been there. And again, the long-term data is also available, which says that patients in whom the disease is very well controlled, ILD has not progressed. And rituximab, yes, most of the data is in favor of rituximab, but these still patients on rituximab also to some extent they have progressed. And tofacitinib, there is not much data. But again, the clinical trial data from tofacitinib had shown very limited percentage of patients have developed a new ILD on RA. So I think we are running short of time. There's lots of questions are there, very difficult to answer at this short span of time. But it was a wonderful discussion and excellent comments from Professor Malviya and Bimlesh and others are involved. And thank you very much, Professor Christopher, for enlightening us about RA and other comorbid problems. Thank you. And over to you, Dr. Dharmanand sir, for moving on to the next session.
Yes. Good morning, one and all. We had a wonderful starter, and then we'll move on to the main course of the meeting. And when a rheumatologist sees a patient in the clinic, he wishes he has an access to a crystal ball and predict the prognosis and decide which patient would do well and which patient would not do well, and decide the intensity of the therapy based on that. Unfortunately, we are not yet there, and we have none other than Professor Christopher Edwards to discuss this topic of predicting disease progression and poor outcomes in patients with rheumatoid arthritis. And he is a professor of rheumatology in University Hospital Southampton, UK, and is also associate director, Southampton NIHR Wellcome Trust Clinical Research Faculty. He has been a member of multiple international committees for guidelines for the management of rheumatic disease. He has the first-hand exposure to all the therapeutic armamentarium available to us. And he's also the clinical lead for the development of guidelines for usage of radiology in the diagnosis and management of rheumatoid arthritis. Over to you, Professor Edwards.
Hello, my name is Chris Edwards, and it's a real pleasure to be with you at the meeting. And I'm now going to spend some time thinking about predicting poor prognosis and progression in rheumatoid arthritis. And I want to do this in a couple of different ways. So classically, we think about the factors that predict poor prognosis, such as having high levels of autoantibodies like rheumatoid factor and anti-CCP. But I want to take this a little bit more broadly and thinking about progression of undifferentiated inflammatory arthritis into rheumatoid, and also perhaps to link it to other comorbidities and the progression to cardiovascular disease, and also to touch a little bit on progression and the severity of other forms of the disease, including adverse events like infections. And of course, no infection is more important to us at the moment than COVID-19, and I'm going to mention a little bit about that and the risks of the therapies that we use. Okay, so let's think a little bit about the management of early rheumatoid arthritis and the importance of managing the disease early on. Behind this slide lies hundreds of different studies reminding us that we should treat people early because that prevents progression to the worst disease, that we should have tight control, we should set a target. And of course, we have a number of therapeutic choices and therapeutic options that we can use. Now, I'm going to talk a little bit about some of the biological therapies and JAK inhibitors, but we also need to remember that for most, and in fact many patients, conventional synthetic DMARDs will be the drugs of choice. And so the early use of drugs like methotrexate are also vitally important. Okay, so here are the classical features of poor prognosis, and these are pulled out in various different recommendations, various different publications. We know the presence of autoantibodies, not just their presence, but the height of their titer, how much antibody is present, predicts worse prognosis. We know that erosions being present predicts worse prognosis in the future, so erosions predict more erosions. We know poor function, as mentioned by Hack, and the presence of high disease activity, which can be measured in a number of different ways by high scores, but also by high ESR and CRP. And then, of course, there are other features such as demographic features and social features such as smoking and BMI, which make disease more likely, make it worse, and make it more resistant to treatment. And we all know what happens when the prognosis is poor and we do nothing about it. We end up in a situation where people's hands are damaged in the way they are in the picture of this patient. So identifying poor prognosis and thinking about when we identify what we do differently. When you see someone with poor prognostic factors, do you treat more aggressively? Do you treat more quickly? That's the key to this and something I'd like you to be asking as I show you the data as we go through the talk. So let's start by thinking about a patient. Here's a 35-year-old woman, attends the clinic with a new diagnosis of rheumatoid. And initially, she'd had a number of features which you may say are poor prognostic features. She had multiple tender and swollen joints. She had a high ESR, a high rheumatoid factor, and a high anti-CCP. If we look at blood tests, she has a normochromic normocytic anemia and raised platelets, common in an inflammatory process, and she has moderately raised ESR and C-reactive protein. And so I think taken together, this is starting to look like someone with a poor prognosis that we'd really want to treat and treat soon and treat aggressively. And then the ultrasound, although the x-rays look normal, the ultrasound identified some erosions, particularly in one joint. So here's another poor prognostic factor. How would you treat this Well, my approach was to give her an intramuscular depomedrone. We'll come back to thinking about corticosteroids in a moment. To start her on methotrexate, which would be my default position. And although sulfasalazine is often used and considered to be a lower risk, I often worry that sulfasalazine doesn't treat all of the immunological features of rheumatoid. And I see some patients in whom extra-articular manifestations are more likely unless I use methotrexate. Of course, methotrexate is not always possible, not always tolerated, but my preference would be for methotrexate. So what about if we change some of the features of this patient? If she was seronegative, would you treat her in the same way? Because that would presumably reduce the feeling that she had a poor prognosis. And what if the ultrasound showed no erosion? Would this change the way you treat her? And finally, if she was seronegative and her symptoms had only been there for 2 weeks, you may be nervous at this stage that she had another form of inflammatory arthritis or a reactive arthritis that might improve, and you might give some steroids and then wait for a period of time before making a definitive decision. So here are some questions. Can you predict RA, the people who will progress to RA? Can you predict the severity of the rheumatoid? Can you predict the comorbidities that are going to be present? And can you try to get an idea of predicting response to treatment? And some of the latest stratified medicine studies attempt to do this. And I'll touch on one or two of those. So let's think about the development of rheumatoid. And this comes from a piece of work from the Karolinska Institute. And it looks at individuals on the left-hand side who have a genetic susceptibility to rheumatoid, and then are exposed to different environmental challenges. And they start to lose immune tolerance in mucous membranes, like the mouth, like the lungs, and like in the gut. The citrullination of peptides, leading to autoantibody formation, increasing titers of these antibodies. And then you get into this pre-rheumatoid stage, when it's not quite rheumatoid yet, but it's inflammatory, and then into proper seropositive rheumatoid arthritis. And we'll come back to this slide in a moment. Should we be thinking about early rheumatoid as a slightly different disease? And therefore, in the future, might we use slightly different drugs at different stages of disease? This is some work from Karim Raza in Birmingham, looking at the synovial cytokines in patients with rheumatoid early on in disease. And the exact detail of the science doesn't matter, but if you look at those headline cytokines, IL-2, IL-4, IL-15, interferon gamma, that are seen particularly in early disease, they're very T-cell type cytokines. And that might increase our interest in using different therapies that will have an effect on these sorts of cytokines. T-cells can be inhibited using co-stimulation inhibitors such as abatacept, for example, which I show in the cartoon on the right-hand side. Now, if we're going to think about who progresses on to most severe rheumatoid, we have to think about, of the people with inflammatory arthritis, who progresses on to rheumatoid arthritis itself. And these features are shown in various different classification criteria. And you can see them on the left-hand side for the ACR-EULAR classification criteria. So you're more sure of disease, and you're more sure of worse disease if there are more joints involved, if there is seropositivity, and if there are acute phase reactants, and if the disease has been there for a longer period of time. And various groups have tried to come up with predicting development of rheumatoid arthritis tools. This is some work from the Netherlands, and they have a questionnaire on the left-hand side, which you accrue points as you get these different questions. So how long ago did the disease start, and how high is the VAS score, and is there early morning stiffness, and is there seropositivity? And that can put you into different groups. And on the right-hand side, you can see here are the percentage of individuals who still don't have rheumatoid arthritis. And in the red line, score 7 to 12, when all those points are added up, you can see by 60 months, only about 20% of people don't have rheumatoid. So you can predict progression to some extent, and that's important. So if we're going to predict and change progression, we can change that progression by treating early. And this slide illustrates that, the natural course in yellow, orange color, and late treatment deviating the line a little, and then early aggressive treatment in green, lowering the trajectory of that disease severity in the best way. And if you treat early, and this is old work now, here are some definitions of disease and it's how early it is. So late early is LIRA, and very early is less than 3 months. The late early is 3 months out to 3.5 years. And you can see the difference in the amount of joint damage that occurs, even in this difference between early and very early. So very early treatment reduces the progression to more serious, more damaging disease. And people think that's because there is this idea of a window of opportunity. If we treat early, we fundamentally change some of the immunophenotype of rheumatoid, and that change may change B cells. And here's the Prairie study. This was published last year. This is using rituximab in this early pre-rheumatoid arthritis stage. And you can see the rituximab line and the placebo line here. And the fact that after treatment with rituximab, there's a separation, but eventually by 36 months, you've delayed the onset of rheumatoid, but you haven't stopped it completely. And then finally, just an advert for the Apipra study. This uses abatacept in this early population, inflammatory sounding joint pain associated with positive autoantibodies. And this is yet to be published. Andy Cope's the lead clinician involved in this at King's in London. So we're waiting to see. So can we delay or even prevent the development of rheumatoid if we treat early enough? So what about thinking about other features such as comorbidities and trying to reduce that, because that's important in the severity of disease? And one of the reasons for treating earlier might be that if you look at this data here, that there is less comorbidity in early disease, less serious infection, less congestive heart failure. And so before people progress to this high comorbidity disease, it might be better to delay that and reduce the likelihood of that by treating inflammation early on in disease. And there's one important thing. This slide from the Corona Registry in the States shows how anti-TNF can reduce the likelihood of cardiovascular events, and methotrexate can do that as well. But it also makes a very important point that even very small amounts of prednisolone, less than 7.5 milligrams in long-term use, can almost double the likelihood of cardiovascular events. And this is one of the reasons why the latest suggestions for the ACR rheumatoid recommendations say try to avoid steroids wherever you can, which is a bit different to the EULAR guidelines. I'm going to show you a little bit of information from the Global Rheumatology Alliance report in COVID-19 and its effects in inflammatory disease. And they've collected several hundred patients and tried to look at the likelihood of a poor outcome as measured by hospitalization with COVID associated with our patients and different features. So if you look at the features on the left-hand side, greater than 65, and then jump over to the right-hand side, the far right column, and you can see the p-value. And you can see individuals over in this column, those that are greater than 65 have p-values saying that they are much more likely to do badly. The diseases themselves make little difference, but comorbidities you can see have the same sorts of effects, hypertension and lung disease, as you might predict. And if we look now at prednisolone at the bottom, greater than 10 milligrams of prednisolone is associated with a worse outcome in our patients. Although reassuringly, if you go slightly further up in the table, you can see the use of biologics and TSD-MARDs, if anything, seems to be associated with a reduced risk of a poor outcome with COVID. So perhaps reassuring information. So let's go back to these poor prognostic features that I've just mentioned: rheumatoid factor and other autoantibodies, erosions, poor function, persistent synovitis, and high disease activity, and see how they're used in the latest iteration of the EULAR rheumatoid arthritis recommendations. So here we are starting with the diagnosis of rheumatoid, if possible, use methotrexate, and then see what happens for a period of time, aiming for a target. And then we have, if people aren't doing well on the CSD-MARDs, the opportunity to think about using biologics and JAK inhibitors. Of course, we're not always in a situation with all our patients we can do this. And actually combinations of CSD-MARDs can often do very well. But you can see here the use of biologics and JAK inhibitors in those individuals who fail their CSD-MARD but have the poor prognostic factors as mentioned in the slide there you can see in the middle. And on there is also, importantly, a poor prognostic factor of failing at least 2 CSD-MARDs. And finally, just to say for the future, predicting prognosis and predicting response of therapy is likely to come from stratified medicine studies. This highlights some which are now starting to be published, and I was just looking out for these. One of these is in the Lancet at the moment, just about ready to be published. That's the R4RA study. And this is taking synovial biopsies in patients with rheumatoid, really defining the immunophenotype of patients and trying to use that to predict severity and to predict response to treatment using both the histology scores. For example, if you have more B cells, are you more likely to respond to rituximab than tocilizumab? And these studies are just about ready to be published. Okay, so coming back to this slide, we know what happens when the prognosis is poor, so we try to treat early and we try to prevent this occurring by predicting the severe prognosis and acting appropriately. And here are my final conclusions. You can predict the development of rheumatoid, and by treating early during the window of opportunity, we lead to better outcomes. Prognostic factors can help drive our confidence when we're using sometimes powerful drugs. We can also think about poor prognosis in relation to the chronic effects of inflammation and its likelihood of producing comorbidities. And we're starting to be able to predict response to treatment from these immunophenotype stratified medicine type studies. So thank you very much for your attention. Thank you.
Wonderful talk, Professor Edwards. I request the audience to type in the questions if there are any. I've not seen any questions so far. I will take the privilege of asking the question. Professor Edwards, do you think early exposure of the patients to steroids in some form, either depomedrone or oral steroids, will help in determining the prognosis, long-term outcome?
Well, I guess that would depend on, thank you for the question. I guess that would depend on whether we think any control of early disease will help to prevent longer term outcome. And I have to say, I do think that's possible. I mean, one of the very interesting things at the moment is the ACR guidelines for treating rheumatoid, which are in the process of being looked at. They were presented at the ACR in their first version, says really avoid steroids where you can. I wonder if they were influenced by the fear of COVID at the moment, which is influencing all of our thinking. And then the European guidelines, of course, the EULAR guidelines says use steroids, but get them away as quickly as possible. I think the key is however you control the disease, if you do it early and quickly, you're likely to modify people's outcome in the longer term. And I don't see why steroids would be different. My big worry with steroid is just that we leave people on a lot of steroid for a long time, wherever we work in the world. And we all see negative consequences as a result.
Yeah, I agree with you. We agree with you. And is there anything else, like at the time to respond? Say we start somebody on methotrexate and a short course of steroid, and you get a fantastic response in 3 months, and some people don't seem to respond at all. Will that give you a hint that this guy is going to require early biologicals?
Yeah, I think so. I think you're absolutely right. And you pick up a really good point, which is one of the I hope to illustrate in the EULAR guidelines, and it's around this idea of CS-DMARD failure, so failing whether it's methotrexate or sulfasalazine. The moment you fail the first CS-DMARD, you put yourself into a poor prognostic group, and that group of people need greater attention. 60-70% of our patients are going to respond to the first CS-DMARD that we give them to a fairly good extent, but it's those hardcore people who fail one and then they fail a second CS-DMARD, they're very likely to need to go on to other therapies. Now, when you make that decision, I think is a bit debatable, but people will often say you need to be waiting at least 3 to 6 months to be really sure whether someone's responding to a therapy. You have to wait a little bit of time.
And there is one more question.
I can see some very nice questions there about early tofacitinib. Shall I take that one?
Yes. I can't see the questions in my.
Okay, I can see something coming up. So there's a couple that I'll just mention. So there's a comment here that says in India, tofacitinib can be used cheaply. And as a result, do you think early tofacitinib usage will be good or bad even before methotrexate? And I think this is a great question. So imagine a situation where we have JAK inhibitors and they're cheap. And for some of them, imagine a situation where we have longer follow-up so we know that nothing new happens in terms of adverse events. I think if that was the case, we might use JAK inhibitors right at the start of treatment. I think we might stop using methotrexate because not all patients like it. And if you look at the speed of onset of many JAK inhibitors, we may not even need to use any steroid at all. So I think, that's not what we're doing at the moment, but I can imagine a situation where we need the strategy studies to see if starting with a JAK inhibitor is the way to go. But I'm very tempted by that idea. I think that's very interesting.
I think we will move on. The time restrictions always there. Extremely thank you for a wonderful talk, and stay with us for the next case discussions as well. And over to you, Dr. Maya, for the next deliberations, next set of cases.
Yes, good morning, everyone. So we had a great start and great presentations in the beginning, followed by Dr. Christopher. So now we'll be having 3 back-to-back case presentations in the following sequence. First, we'll be having a presentation from Dr. Kavya, who has done her DM Rheumatology from Nizam, Hyderabad, and is presently a consultant rheumatologist at Anvitha Arthritis and Rheumatology Center in Vijayawada. Followed by Dr. Arun Kedia, who is a consultant physician and has special interest in rheumatology, presently a consultant at Life World Hospital, Raipur, Chhattisgarh. And lastly, we'll be having a very interesting presentation by Dr. Parul Baldi, who has done her MD followed by SCE in rheumatology as presently doing her private clinic as a consultant rheumatologist in Indore. So we'll be starting with Dr. Kavya. Over to you.
Good morning, everybody. This is Dr. Kavya from Andhra Pradesh. So here I am presenting a case of a 57-year-old female patient. She is a non-obese, non-smoker. She is symptomatic for the past 15 years with inflammatory type of polyarthritis involving small and large joints, which is symmetrical. And on evaluation, her RF and anti-CCP antibodies are high titer positive and ANA was negative by immunofluorescence. Next. So she was diagnosed as a case of seropositive rheumatoid arthritis and started on methotrexate, which was hiked to 20 milligrams per week, and followed by leflunomide was added and increased it to up to 20 milligrams per day. As she had inadequate response to double DMARDs and she had sulfur drug allergy, so we had to go ahead with a biologic, that is rituximab 1 gram 2 doses were given in 2012. With the background immunosuppression of methotrexate, leflunomide, and low-dose steroids. With rituximab, she attained remission and sustained it for up to 1 year. And again, in 2013, after 1 year, she had a flare of arthritis and so received the second cycle of rituximab, same dose, with the background immunosuppression of methotrexate, leflunomide, and low-dose steroids. And with second cycle of rituximab, she maintained remission up to 5 years, that is from 2013 to 2018. Next slide. Next slide. So, but in these 5 years, she had recurrent episodes of leukopenia, the least count being 2,400, and along with that, she had recurrent UTIs. As she was in clinical remission, her steroids were stopped, followed by leflunomide was stopped, and she was maintained on 20 milligrams of methotrexate. And the UTIs and leukopenia are managed with antibiotics and temporarily stopping the methotrexate. And for evaluating leukopenia, a bone marrow biopsy was done in 2016, where it was showing reactive hyperplasia with 65% cellularity. So there was no bone marrow depression. And after 5 years of second cycle of rituximab, in 2018 May, she had a flare of arthritis along with leukopenia on 20 milligrams of methotrexate. So she received her third cycle of rituximab, 1 gram 2 doses. Next slide. But this time, even after 4 months of taking rituximab, she doesn't have any response, requiring daily NSAIDs and steroids of up to 10 milligrams per day to control her arthritis. So leflunomide was added to methotrexate, but she developed leukopenia, so we could not continue the double DMARD combination. So post rituximab 5 months, because of active arthritis, she was started her second biologic agent, that is anti-TNF, adalimumab, 40 mg subcutaneously every second weekly. After taking 2 doses of Edali, she had a very good response and her DAS28 ESR has come down from 6.2 to 3.7 and she was able to stop her NSAIDs and steroids were reduced to 5 milligrams. But she could not sustain this response with the further dosing of Edali. So with further next 4 doses, she lost the response with worsening of arthritis. Next slide. So in March 2019, she received her third biologic, that is tofacitinib 5 milligrams BID along with leflunomide. But again, she had leukopenia with lymphopenia of 650. Because of moderate lymphopenia, we had to reduce her tofa dose from 10 milligrams from 5 milligrams BID to 5 and 10 milligrams alternate day, along with reduction in dose of leflunomide to maintain lymphocyte count of more than 1000. And throughout the disease course, she was given both folic acid as well as folinic acid supplementation to control her leukopenia. And we have evaluated her causes of leukopenia in her. We have done a repeat ANA, which was negative by immunofluorescence, and viral markers are negative, and ultrasound was showing no evidence of organomegaly or any evidence of lymphadenopathy. And she was not on any other medication to explain her leukopenia. From this March 2020, that is after 1 year of tofacitinib, she was clinically better, so steroids were stopped, and leflunomide was also stopped because of fluctuating TLC count. And clinically, as of now, she had no tender or swollen joints. She doesn't have early morning stiffness from the beginning of her illness. But these are her lab parameters from March 2020 to October 2020, where clinically she had no tender or swollen joints, but her inflammatory markers, that is ESR and CRP, are persistently high, and her patient global assessment was at 30 mm constant, and her DAS ESR was showing moderate disease activity. Because of persistent high inflammatory markers, we had done an ultrasound of the joints, MCPs, wrist, knees, and MTB joints to know for any subclinical information, which was showing tenosynovitis in the hands as well as MCP joint synovitis with grade 1 PD signal. And for the past 2 years, when she was on anti-TNF and TOFA, she did not have any infections and did not require any antibiotics. But she persisted to have mild to moderate lymphopenia. Next slide. So this is a timeline of events. So she had a failure of double conventional synthetic DMARDs followed by rituximab. First 2 cycles of rituximab, she had an excellent response and achieved clinical remission. But third cycle of rituximab was failed, and her second biologic, that is anti-TNF, was failed, probably primary failure, and followed by her third biologic DMARD, tofacitinib, with which she had inadequate response because of persistent high inflammatory markers and subclinical inflammation in ultrasound, as well as she persisted to have mild to moderate lymphopenia. Next slide. So these are her lab parameters. So here she started developing leukopenia after her second cycle of rituximab, and the least count was 2400. And her inflammatory markers are persistently above 60 mm, that is ESR was always above 60 mm, even when she was in clinical remission after her first 2 doses of rituximab. Next slide. So we can see persistently high inflammatory markers, that is ESRs, and she never had neutropenia. Her neutrophil count was always above 2500. She only had mild to moderate lymphopenia, that is counts between 500 to 1500. So, and her DAS ESR was showing moderate disease activity as of now. Next slide. So we reviewed the literature to know what's the cause of a refractory rheumatoid arthritis. So as of now, there is no arbitrary definition for refractory rheumatoid arthritis. So they say failure of at least 2 conventional synthetic DMARDs plus failure of at least 2 different biologic agents with a different mechanism of action, that is at least 1 anti-cytokine targeted biologic DMARD, that is either anti-IL-6 or anti-TNF, and 1 cell targeted biologic DMARD, that is either anti-B cell or anti-T cell biologic DMARD failure. Along with that, they should have a active disease, that is DAS28 with DAS28 ESR of moderate or high disease activity and persistently raised inflammatory markers, are unable to taper the glucocorticoid dosage of less than 10 milligrams per day, and signs of active disease either clinically or by ultrasonographically. And nearly 20% of the patients progress to a third biologic DMARD, and among them 5% even fail the third biologic DMARD. And to know what are the causes of refractory rheumatoid arthritis, it can be pharmacokinetic refractory, that is, we are targeting the drug correctly, but because of development of anti-drug antibodies or HACA, there is there is increased clearance of the drug leading to decreased efficacy. And the other is the non-inflammatory drivers, that is presence of central pain mechanisms like fibromyalgia or presence of secondary degeneration because of damage to the joints can cause increased pain and increased patient global assessment and reduced quality of life. And the third is the incorrect drug targeting. We know that rheumatoid arthritis is a heterogeneous disease, and there can be genetic heterogeneity, clinical heterogeneity, as well as cellular heterogeneity. As of now, we are targeting the drug based on clinical phenotype and clinical decision, but the cellular heterogeneity is different. So they can have B cell predominant disease, but if you target the disease by anti-T cell therapy, there can be failure of the failure to control the disease. And the other scenario is overlap with other autoinflammatory phenotypes. Some patients with rheumatoid arthritis can have episodic arthritis involving one or two joints with associated skin inflammation and raised leukocytosis and fever. Such patients can respond to colchicine, but such clinical features are not present in our patient. And the third is the FLS-driven persistent inflammation. Here, there can be no signs of systemic inflammation, and even the antibodies can be negative, but the FLS drives the inflammation locally and causes the joint damage. Next slide. So, on coming to causes of leukopenia in this patient, so lymphopenia, the Wayback study done in 1989 was showing lymphopenia could be marker of high disease activity in rheumatoid arthritis patient, and this is independent of the disease activity as well as independent of the DMARDs they are taking. So lymphopenia itself is a marker of high disease activity. And as of now, we have ESR and CRP as the two most important lab parameters to assess the systemic inflammation and disease activity in rheumatoid arthritis. But these two markers are prone to change with age, gender, renal failure, or with hemoglobin levels. So now two important inflammatory markers are emerging, that is NLR ratio, neutrophil to lymphocyte ratio, and PLR ratio, that is platelet to lymphocyte ratio, which were considered as which showed positive correlation with ultrasound, clinical, as well as lab parameters of disease activity in rheumatoid arthritis. And neutrophil increases as the disease progresses because of increase in GCSF, and lymphocyte count tend to decrease with progression of RA because of dysregulated apoptosis as well as increased trafficking of lymphocytes from peripheral blood to the site of target organ. So this is the cause for lymphopenia in patients with autoimmune disease. And this NLR and PLR ratio, though they cannot differentiate between patients of moderate and high disease activity, but high NLR and PLR ratio has shown that there is ongoing disease activity in rheumatoid arthritis patients. And coming to drug-induced causes of leukopenia, as of now, my patient is on the drug TOFA and all other conventional synthetic DMARDs are stopped, but still the leukopenia is persisting. And TOFA can also cause transient changes in hemoglobin, neutrophil, and lymphocyte count. And the lymphocyte count initially increases up to 3 months. Later on, they decreases and stabilizes over the next 48 months. But my patient has developed leukopenia even before starting the TOFA, and it was continuing till date when she was on TOFA. And lymphopenia is associated with severe infections in rheumatoid arthritis, and the risk of infections increases with a count of less than 1,000, and it even increases when the count goes below 500. So, next slide, please. So why I'm presenting this case is how to manage further this case in this context of multiple biologic failure along with underlying lymphopenia, which is persistent in this patient, and how to assess disease activity in them, as this patient is in clinical remission and as of now she is happy with the treatment going on, but still there is subclinical inflammation going on by ultrasound as well as persistently high systemic inflammatory markers like ESR and CRP. And how frequently should CBP be monitored in this patient to minimize the risk of infections? So as of now, I am doing fortnightly her CBP to see for any lymphopenia. So how far should I continue like this, and what's the best next step for her? Thank you.
So, good afternoon, everyone. I thank the WRF for giving me this opportunity. So, before I begin my case, I'll just give a brief introduction and background to the case. My case shall highlight the need for collaboration between rheumatologists and other specialty so as to provide a patient better care and better clinical outcome. We all know that rheumatoid arthritis is associated with a gamut of extra-articular manifestations, and eye manifestations are one of the commonest among them. Scleritis, episcleritis, keratitis, uveitis are amongst the known complications that we see in patients of rheumatoid arthritis. But peripheral ulcerative keratitis is one of the rarest yet devastating late extra-articular manifestation of rheumatoid arthritis, which if identified late or treated late may progress to corneal perforation. It is usually associated with a very poor visual prognosis, and so the disease presents a very big challenge to the clinicians if not identified early. However, the management shall involve aggressive systemic control of the disease and good surgical intervention to improve the stability of the cornea and prevent perforation. Now, with this background, I start my case. Next slide. So the case involves a 52-year-old lady who presented to the ophthalmologist with history of acute onset dimness of vision in the right eye with pain and photophobia. The ophthalmologist saw her and diagnosed her as a case of peripheral ulcerative keratitis with a small impending corneal perforation. He ruled out the infectious causes of keratitis, and when he saw that there were long-standing joint deformities, he took no time to refer the lady to the rheumatologist. In the meantime, he evaluated her for dry eye, and what he found was the Schirmer test positive in both the eyes with almost 0 score. So after doing initial surgical protection of the cornea, he referred the case to the rheumatology department. So when the patient came to us and we took the history, we got the history of polyarthritis which began with pain in both wrists, fingers and ankles 10 years back, which was associated with an early morning stiffness for more than 1 hour. It used to be getting relieved with medications which a patient used to take from a general practitioner. In the meantime, she consulted orthopedicians who diagnosed her as a case of arthritis, but the patient had a poor follow-up with any of the doctors. In the meantime, the patient was taking over-the-counter drugs and controlling the pain. Throughout these episodes, patient took multiple alternative treatments, but because of the poor relief, the compliance to any of the treatment was poor. So the pain progressed to multiple other joints in the form of elbows and shoulders in 2 years. The patient also gradually developed deformities in the hands. And when the patient presented to us, she had active arthritis in the wrists, the shoulders, and she had neck pain. Next slide. So on clinical examination, we could see the active synovitis in the wrist. There was swelling in the MCP joints. There was subluxation of the MCP joints. And she had classical RA deformities in the form of the Boutonniere deformity. You could see the ulnar deviation of the fingers. There were Z thumb deformity. There was swan neck deformity. So there was evidence of long-standing RA. And at the same time, because the patient had active synovitis and swelling in the wrists and the MCP joint, so we had the patient who had a long-standing RA with active disease. So this was a case of classical RA with joint deformities with active disease. Next slide. So we investigated her with normal CBC. Her ESR was elevated at 95. CRP was very high, 54. Rheumatoid factor was positive. The anti-CCP titer was very high. Her ANA was negative. Viral markers were negative. The baseline LFT, renal functions, blood sugar, and thyroid function tests were normal, and the chest X-ray was normal. So over this blood parameters revealed that this patient had very high disease activity. So the next slide. So our diagnosis was that this patient had a chronic active deforming seropositive rheumatoid arthritis who had a very high disease activity with the clinical, the CDI score was 56. There was evidence of keratoconjunctivitis sicca, and patient presented with corneal melting as an extra-articular manifestation and as a complication of keratitis. Next slide. So this patient required a very active management. So we started off with injection methylprednisolone pulse therapy in the form of 500 milligrams for the first 3 days. And then we put her on oral prednisolone in a tapering dose. The local eye care was being taken care by the ophthalmologist. At the same time, this patient was put on methotrexate 15 milligram once a week and tablet hydroxychloroquine 200 milligram twice a day. The patient had a good follow-up, and during follow-up, we found that the vision started improving in the right eye, but there was a residual corneal scarring left over the right eye. At the same time, her joint symptoms also improved, but there was some residual pain and the deformities persisted. Next slide. So coming to the pathogenesis of peripheral ulcerative keratitis in rheumatoid arthritis, we know it tends to develop more frequently in the peripheral cornea as against the central avascular cornea because of the dense vasculature of the peripheral cornea, which facilitates the infiltration of the inflammatory cells. The proposed mechanisms are a combination of immune-mediated vasculitis and leading to vascular occlusion. There is severe cirrhosis associated with secondary Sjogren syndrome, and there is leukocyte chemotaxis and release of lysosomal enzymes. There is also an imbalance between the matrix metalloproteinases as well as the tissue inhibitor of matrix metalloproteinases, which leads to inflammation and destruction of the cornea. Next slide. So coming to the prognosis, most of these cases, if not identified early and treated early, will have multiple complications. There could be local complications in the form of loss of vision, perforation, corneal scarring, and cataract. It also indicates towards a high systemic complications in the form of probability of high risk of extraarticular manifestations and high CV events leading to high mortality in the next 5 years. Next slide. So what do we learn from this case? So this case teaches us that combined ophthalmology and rheumatology consultations can save this patient from an impending devastating complication. And so we need to develop a prompt referral system between rheumatology and other disciplines so as to provide a better patient care and good clinical outcome. At the same time, all patients with long-standing rheumatoid arthritis need to be evaluated for extraarticular manifestations. Next slide. And what else do we need to explore? We need to study more into the corneal and ocular immunology, and so that we can use more judiciously the available molecules for the treatment. We still have absence of evidence-based treatment recommendations, and so we need to develop recommendations for the immunosuppression and judicious use of biologicals in such cases. We also need to probably develop guidelines regarding routine eye checkup in patients of rheumatoid arthritis so as to have a better patient care. Next slide. So thank you for patient listening.
Good afternoon, everyone. Thank you, Team WRF, for giving me this wonderful opportunity. Today, I'm going to talk about a very unusual complication of rheumatoid arthritis. Let us see how it progresses. So this is about a 38-year-old female who came from West Bengal with basically chief complaints of swelling of distal part of both upper and lower limb extremities that happened bilaterally for last 1 year. It appeared simultaneously in both the extremities, and it evolved in such a way that the right side got involved more than the left. Gradually progressive, and it did not have much diurnal variation. Coming to the negative history, she did not report any fever, any redness or pain over the affected area. She did not have any facial puffiness, any nocturia or frothyuria to explain her swelling. No shortness of breath, no abdominal distension alongside, or no history of any recurrent diarrhea. But she had a very significant and dramatic past history. She had polyarthritis for last 16 years, which typically involved small joints symmetrically on both the sides. She had typical early morning stiffness for 2 hours, and for the last 5 years, she had developed small joint deformities, which rendered her incapable of doing routine activities. But she had never seen a rheumatologist before, and she was only taking alternative medicines without much relief and painkillers side by side. Other than that, there was no other significant medical history. Coming to the clinical examination, as we can see in the pictures please. So in the pictures, we can see there is a very firm, non-tender, non-pitching edema, which was extending up till the forearm. And there were typical swan neck deformities that can be seen in the pictures. Next picture, please. In this picture, the edema, the nature of edema is clearly visible. Next slide, please. There were similar findings in the lower limb. We can see some form of deformities and subluxations involved. She had a tender joint count of 6, and the swollen joint count, although a little difficult to ascertain, was around 10. There was no lymphadenopathy anywhere, inguinal, axillary, or otherwise. There were no skin changes, and rest of the systemic examination was normal. Next slide. So to summarize, she was a 30-year-old female with untreated inflammatory polyarthritis for 16 years. She was on alternative medicines and had now had fixed joint deformities for the last 5 years, and now came with chronic peripheral edema, which was gradually progressive and involving the right side more than the left. Next slide, please. At this stage, we had a few differential diagnoses in mind. The first one was obviously untreated hypothyroidism with florid mixed edema. In a country like India, filariasis was obviously not forgotten. Underlying malignancy, especially lymphoma or some kind of myeloma, which was presenting like this. Long-standing nephrotic syndrome, untreated, could be presenting like this. Another likely diagnosis was lymphedema that was secondary to inflammatory arthritis or underlying connective tissue disease in her case. Another, a little bit of a rare diagnosis, IgG4-related disease-mediated lymphangitis. And lastly, in the background of untreated rheumatoid arthritis for so long, we also thought of secondary amyloidosis being presented in this way. Coming to investigations, she was found to have normocytic normochromic anemia, 8.7 grams hemoglobin, a very high ESR of 123 millimeters. She had a raised globulin count of 4.6, although her albumin was fairly on the normal side. Very high alkaline phosphatase levels. Surprisingly, she had rheumatoid factor and anti-CCP negative in spite of having typical features. As the diagnosis of rheumatoid arthritis was most likely, the TAS28 ESR was calculated and was found to be very high, 6.61. We did a routine urine and it had trace proteinuria, nothing much. So we didn't go ahead with the quantification. Thyroid function and IgG4 levels were found to be normal. We went ahead with a serum protein electrophoresis, which showed polyclonal increase in the globulin levels. And lastly, we did a filaria antigen, which was found to be negative. Next slide, please. This is an X-ray of the hand, which shows gross subcutaneous edema. Also, there is evidence of juxta-articular osteopenia. And on a closer look, it will also show some erosions here and there, and with some carpal crowding. Next slide, please. We went ahead with the imaging and radiology in this patient. An X-ray chest was done along with ultrasound abdomen, which was found to be normal. There was no organomegaly or any lymphadenopathy. Having malignancy in mind, and because the right side upper limb swelling was maximally present, so we did a USG and mammography of the breast, which was normal. We went ahead with a venous Doppler of right upper limb, which was found to be normal. Echocardiography was normal. To better ascertain the erosions in the wrist, we did a power Doppler, and power Doppler was suggestive of erosion, synovitis, and pannus formation. As at this stage, we had lymphedema at the topmost priority of differentials. We went ahead with a lymphoscintigraphy, and it showed abnormal lymphatic flow with delayed visualization and all the draining lymph nodes. In fact, the axillary lymph node was in the right side was not visualized until about 4 hours. The final conclusion was given as obstructive lymphedema in the right upper limb and right lower limb, and non-obstructive type in the left upper limb and left lower limb. At this stage, we tried to ascertain the cause of lymphedema, and we decided to go ahead with a biopsy of fat pad biopsy. And it indeed showed eosinophilic amorphous material with few inflammatory cells and it was positive for amyloid congruent stain. We could not go ahead with polarized microscopy for this, but an immunohistochemistry was done, which was suggestive of AA type amyloid deposit. So the final diagnosis at this stage was, this is a case of seronegative rheumatoid arthritis, which was complicated by secondary amyloidosis and presented with lymphedema, maximally involving the right upper limb. So at this stage, we gave her intramuscular depomedrol and also started her on oral methotrexate and sulfasalazine therapy along with physiotherapy and exercise. After 2 months of follow-up, her DAS28 had reduced, but it was still having moderate disease activity. But unfortunately, there was no resolution of edema, which was quite expected given her nature of edema was quite firm and non-tender. But because her edema did not resolve, she was eventually lost to follow-up. She had a very short follow-up. Next slide, please. So this gives me an opportunity to discuss about lymphedema. Lymphedema is a very rare extra-articular manifestation. It is mostly reported in, it has been reported in RA, also in cases of psoriatic arthritis, Angst-Pond, and systemic sclerosis. It could be either due to lymphatic formation excess or obstruction to the lymph flow. Next point, please. There are a few plausible causes that has been mentioned in the literature. One is chronic lymphangitis, which is a part of the inflammatory process and extending to involve the lymphatic vessels. Lymphatic blockage has been cited as a cause in a few studies due to fibrin and its degradation product. In fact, there is a case series in which fibrin degradation product has been found to be raised in such patients. Immobility, which can cause functional lymphatic flow. Surprisingly, it has been mentioned that there is no correlation with rheumatoid factor or anti-CCP in developing this sort of presentation. Next slide, please. Which also gives me an opportunity to discuss the incidence of secondary amyloidosis in our patient. The prevalence is quite varied. It varies from as little as 5% to as much as 78% in different case series. There is an Indian study from SGPGI which had showed that 1/4 patients evaluated with abdominal fat pad biopsy had shown clinical disease in the form of either renal or gastrointestinal. There has been poor prognostic markers, which is mean duration of the disease, the extent of deposits, which can be graded, the extent of deposits in the fatty tissue. Renal dysfunction at presentation is a very poor prognostic marker in such cases, and disease that has been untreated for a very, very long time. In a cohort of Japanese patients, it has been found that serum amyloid A 1.3 allele has been found to be a poor prognostic factor. Treatment I will discuss in the next slide. So to outline the treatment of chronic lymphedema, aggressive disease control that goes without saying. Then decongestive lymphatic therapy, which has 4 cornerstones. One is skin care, the other is manual lymphatic drainage, and then using short, stretchy, elastic bandages, we provide compression to the patient, and specific physiotherapy and exercise. It has been seen that usually it responds very poorly to treatment, although there has been some individual cases which showed good response with etanercept. And although there was one case in which tocilizumab was found to increase the lymphedema. Coming to amyloidosis secondary to RA, even after the development of amyloidosis, biologics was found to work very well, especially etanercept, rituximab, and adalimumab. In patients who have had a renal manifestation of amyloidosis, immunomodulatory agents such as cyclophosphamide has found to be working well. That brings me to my final slide, in which we have a few points to think about. Which patients of inflammatory arthritis, specifically rheumatoid arthritis, to be screened for secondary amyloidosis? Will early aggressive management lead to better outcomes in patients, especially with amyloid? Although it has been seen that after using biologics for so many years, we have found a reduction in the levels of amyloidosis seen. And a very important point about relevance of subclinical amyloid deposits. There has been case series which has shown that in about 70% of cases, subclinical amyloid deposits does not develop into clinical amyloid. So with that, I would like to end my case. Thank you so much. Thank you for the opportunity. Thank you.
I thank all the presenters for the wonderful presentation, and we'll be having a discussion for the next 15 minutes. And I would like Dr. Kavya to come on screen first. We'll be taking questions. So first of all, we have a comment from Dr. Professor Malviya that okay, so the risk of having leukopenia is obviously, as we know, more with the number of DMARDs, conventional DMARDs that we combine, and the risk is significantly increased if we combine methotrexate and leflunomide. So we have another comment that why leflunomide was used again and again in view of leukopenia. So there is a risk of permanent leukopenia, says Dr. Malviya, in cases of combining methotrexate and leflunomide. And also he has a comment whether iguratimod could have been added. We have a similar question from Dr. Ankur also, whether iguratimod is worth trying in these cases. So yes, iguratimod has come up as something between the conventional DMARDs and biologics, and though it has been approved by APLAR and not yet by EULAR and ACR recommendations, we still do not have any place for iguratimod. But yes, I think it would be worth trying in case that we have a very high risk of the patient is still not being planned on biologics and is not tolerating or inadequately responding to conventional DMARDs. But we have still a little time to go, I think, before we have a more substantial data on iguratimod. But though, yes, it has been shown to have significantly reduced inflammatory markers, synovitis, and give significant amount of relief. Then again, we have a question from Dr. Dharmanand. Will PET-CT be useful for subclinical vessel involvement in persistently raised inflammatory markers? So I think, sir, that PET-CT would be going a little overboard, because I think ultrasound of power Doppler, ultrasound of joints would give us a very good idea about having subclinical synovitis and inflammation inside the joints. And while doing the ultrasound, when we see that there is, we can pick up signals in the vessels, we can look out for erosions, we can look out for synovitis. So that gives, and it has been shown in various studies that ultrasonographic evidence of synovitis, of subclinical inflammation, actually correlates very well with the subclinical inflammation and disease activity. So I think, I don't know how cost effective doing a PET-CT would be. And I think at this point of time, ultrasound would be actually a very good modality to go for that. Then we have a question from Dr. Bimlesh that will bone marrow biopsy be helpful in such cases of leukopenia? So I think, sir, bone marrow biopsy was done in this case and it was not conclusive. Yes, in patients of rheumatoid arthritis, in which you have persistent leukopenia, myelodysplastic syndromes are known to occur in patients of rheumatoid arthritis. So I think bone marrow biopsy would be a good modality in patients having persistent leukopenia to rule out something like myelodysplastic syndrome. But I think in this particular case, Dr. Kavya, I think you would agree that bone marrow biopsy was done and you had ruled out any kind of myelodysplastic evidence, right?
It was done after 2 years of onset of leukopenia, but it was not showing any dysplastic changes and it is hypercellular.
Yes, so it was not conclusive and we could not get any etiology out of doing bone marrow biopsy in this case, right?
Yes, ma'am.
Okay, so we have another question from, okay, so this is a direct question to you, Dr. Kavya, from Dr. PSR Gupta. One is that what was the status of osteoporosis in your patient? And secondly, from Dr. Ramesh Joyce, what were the vitamin B12 levels? Because we know that low vitamin B12 levels can also lead to leukopenia. So correction of that probably could be a correctable cause.
Regarding first question, a BMD scan was done which was showing osteopenia in her as of now. So she was already on bisphosphonate, that is IV zoledronic acid, because of oral intolerance to oral bisphosphonates. And the second question, B12 and folate levels are done twice in this patient, but it was normal. But we are continuing folic acid supplementation in her. And usually I did not find any difference between folinic acid or folic acid supplementation. The counts are the same, whether we give which one. But as of now, she continues to take folic acid.
Okay, fair enough. So I think that answers the direct questions. Now we have another question from Dr. Bharat, that how do we define difficult to treat rheumatoid arthritis? So I think Dr. Kavya discussed that when we define refractory rheumatoid arthritis, the terminology or the definition is still arbitrary. But usually what we say is that the patient is resistant to or is having inadequate response to multiple therapies which have different mechanism of actions. And usually till now the definition we have is that one agent should be directed towards the cytokines, that is IL-6 or TNF, and the other agent should be directed to the cells, that is the B cells or the T cells. So one agent from both of these categories the patient should have been refractory to when we can label it as refractory RA, right? Okay, so we have a question from Dr. Chetan. Then I think this would be the last for you, Dr. Kavya, pertaining to your case. Was rituximab given in the proper interval or dosage? And what was the reason of failure of rituximab thereafter? So I think you gave the patient rituximab twice, and both of the times you had followed the RA regime. That is 2 grams were given, 1 gram 2 weeks apart. Right, and the patient had response to rituximab for the first 2 times, but the third time the patient did not have response following 4 months after the rituximab.
Yes, ma'am.
Right. So okay. So I think that yes. So a secondary failure to rituximab can actually be, though it has not been documented in rheumatoid arthritis per se, but there have been studies in lupus that anti-drug antibody formation, human anti-chimeric antibody formation in cases of patients who have been on rituximab can actually lead to reduced efficacy of rituximab, though this has not been proven in patients of rheumatoid arthritis. Around 4 to 10% of patients in RA who are receiving rituximab can have antibody formation. But in lupus, particularly in a series of, I think, 77 patients, it was shown that development of these anti-chimeric human antibodies has been shown to reduce the efficacy and rituximab levels in these patients. So this could probably, one of the reasons, be a reason for secondary loss to rituximab, right? So I think we'll come to Dr. Arun's case now. Okay, so Dr. Arun, all right, we have 2 questions from Dr. Sumit Singla. So Dr. Arun had presented basically a case of long-standing rheumatoid arthritis, untreated rheumatoid arthritis, with first presentation as corneal melt or peripheral ulcerative keratitis. So the first question from Dr. Sumit Singla is role of anti-CCP, high anti-CCP antibodies in keratoconjunctivitis sicca in rheumatoid arthritis patients. So I think, Dr. Sumit, we all know that high antibody levels of anti-CCP or rheumatoid factor are known to have extra articular manifestations in rheumatoid arthritis patients. These patients are definitely more prone to have keratoconjunctivitis sicca and hence develop secondary Sjogren's syndrome. So I think that answers your first questions. Also, the second question is, I think, Dr. Arun, if you might want to take it, was any kind of infection ruled out in your case? Because we all know that there can be infectious causes of peripheral ulcerative keratitis. So could that be a cause of causing corneal melt in your patient?
Yeah, thank you, ma'am. I had a telephonic discussion with the ophthalmologist who had sent this case to me, and he had clinically ruled out infection from his end. And it was after that he ruled out the infection that only we could think of starting the pulse methylprednisolone therapy for this patient. He had taken the washings of the cornea for examining under the light microscope, and he had ruled out any evidence of any bacterial or viral infections in this case. So it is very important to rule out infections as the first diagnosis in any case of peripheral ulcerative keratitis, because almost 40% of the cases are due to infections, even in autoimmune diseases. So before we start the therapy, especially the immunosuppressants, it is very, very important to rule out infections.
Absolutely true. So I would agree with that. So, but then again, peripheral ulcerative keratitis, 50% of these patients will have some non-infectious causes, and out of this 50%, around 50% will again be having some kind of connective tissue disease. So that is a very important point. So, okay, fine. So I agree with that point that obviously infection would have been ruled out, because only then the ophthalmologist would have agreed on giving methylprednisolone pulse, right? Okay, so next question is from Dr. Samar, who says that what would be the role of IV cyclophosphamide? So I think when we talk of treatment in cases of peripheral ulcerative keratitis pertaining to rheumatoid arthritis patients, first of all, it is important to know that the treatment, there are no recommendations and guidelines, and the treatment depends on a lot of factors. How much is the severity of involvement, whether there is systemic vasculitis, whether there are features of systemic vasculitis or not. So also I would like to make this point that in around 50% of these patients who are presenting to you with peripheral ulcerative keratitis, this might be an onset of a systemic vasculitis. So you need to be very cautious. You need to have look out for other areas where vasculitis might be, actually impending vasculitis might be there. And when it comes to role of IV cyclophosphamide, I would say IV cyclophosphamide is obviously a very, very good drug for any kind of vasculitis. But in case that your patient has only limited vasculitis in eye, I would say methotrexate, azathioprine, and cyclosporine would be good enough. But in case that you have features of systemic vasculitis or renal involvement, or you see active urinary sediments, then I would say IV cyclophosphamide would be definitely a better option. So as I said, there are no recommendations and guidelines, and a lot depends on the I would say the safety profile of the drug, the extent of involvement of vasculitis, and then again, you have to look out for the other parameters. Then we have a question from Dr. Alok, who asks whether other extra articular manifestations were searched for in this. That is what we were discussing. So Dr. Arun, if you would like to answer whether other extra articular manifestations were searched in this case.
Yes, ma'am. In the initial workup, we did a baseline chest X-ray to rule out any lung manifestations. We did a thorough clinical examination to look out for rheumatoid nodules in the skin, to look for vasculitic ulcers anywhere in the skin which the patient might have neglected. We did a baseline ECG and echo to rule out cardiovascular involvement, and that was found to be normal. Subsequently, after giving pulse methylprednisolone therapy, we also did a BMD of this patient, and we found that there was osteopenia, because that was our crux for deciding the therapy for the future. So except for osteopenia, we did not find any other extraarticular manifestation in this patient. The urine analysis was normal, and there was no active urinary sediments in this patient. And clinically, examination did not reveal any evidence of any neurological involvement also.
All right. Thank you, Dr. Arun. So I think I would come over to Dr. Parul now, if she could come on the screen. So the first question is from Dr. Indrajit. What would have been the cause of raised ALP? So I think raised ALP in most of the cases of amyloidosis comes from liver. So occult involvement of liver or liver amyloidosis would be the most common, and I think the most obvious reason for raised ALP in such patients. But I think, as you mentioned, that the ultrasound of the abdomen was normal, the liver size was normal, right?
Yes, that was there, but I still think it would be because of occult deposits in the liver, along which he had a very low vitamin D levels. So both combined would have resulted in the raised ALP. Although we didn't go ahead with a second biopsy because that was not deemed ethically correct at that point.
Okay, great. So we have another question. Could RS3VE had been a possibility in such case? So I think because of the fact that the edema was non-pitting, this was not kept as a differential diagnosis. Is it so?
Yeah, absolutely. We still did think about this diagnosis, but it was a very long-standing, without any sort of pitting. It was quite firm on palpation, so we didn't really think about it, and retrospectively we also gave her some steroids. Usually if it is RS3PE, it would very promptly resolve on giving steroids
and would have been pitting, yes. So I think I'll take another question, and rest we can answer in the chat box. Can it be amyloidosis presenting as arthritis rather than seronegative arthritis complicated by amyloidosis? This has been asked by Dr. Ramesh Joyce. So I think, sir, this more likely fits into a seronegative arthritis presenting as amyloidosis, because had amyloidosis, first of all, we have a chronic inflammatory state that we can look is going to present into amyloidosis. And secondly, if it would have been amyloidosis leading to arthritis, most of the times it would have been a primary amyloidosis, but we find that there was no monoclonal antibody, right? Monoclonal gammopathy.
Yes, and in fact, immunohistochemistry was suggestive of AA deposit. So that further makes us think that it is secondary.
So that makes us think that it is a secondary amyloidosis, and the most pertinent cause that we can think of is a long-standing untreated seronegative arthritis, right? So I think over to Dr. Dharmanan for the next session. Thanks a lot to all the presenters and the audience.
Thank you, Dr. Meha, for the wonderful deliberations. Next, we will move on to the next lecture. The topic is treating rheumatoid arthritis to target, with special reference to India. The speaker is none other than Professor Vikas Agarwal, who is a professor of rheumatology and clinical immunology in SGPGI, Lucknow. He is the editor of Indian Journal of Rheumatology, and we all know him as one of the excellent clinicians. He has special interest in spondyloarthritis, scleroderma, and drug resistance mechanisms. Over to you, Dr. Vikas.
Good afternoon, everyone. Is my screen available to all of you?
Yes.
Okay. First of all, thanks for the opportunity for asking me to present on this particular topic. And so without wasting any time further, I'll just take back some of the young rheumatologists to the era of 90s, early 90s and late 90s, when the treatment of rheumatoid arthritis was principled on doing no harm because of the drug or the drug toxicities, and sequential monotherapy was the norm, and that too in a low dose, especially for methotrexate. But this changed by the time late 90s were arriving, and the landmark study which changed the concept of this scare of combination of disease modifying drugs was this COBRA trial, which originated from multiple centers in Netherlands, and 155 patients were enrolled, and most of these patients had a disease of less than 2 years of duration with a median of 4 months. And this therapy, for the very first time and very innovatively and very bravely, actually compared the efficacy of combination therapy in form of sulfasalazine, low dose of methotrexate, and a very high dose of prednisolone, which was tapered over 28 weeks, versus sulfasalazine. And this landmark study clearly established the fact that the patients who received combination of disease-modifying anti-rheumatic drugs with prednisolone, they did remarkably well in achieving ACR 20 and 50 responses at 1 year as well as at the end of 2 years. Not only that, this study is still being quoted. The efficacy of this a limited period intervention of 6 months actually continue to benefit subjects till 5 years. And very recently, last year, the efficacy of this trial was published in form of decrease in mortality in patients of rheumatoid arthritis in patients who had received combination therapy in the COBRA trial. So clearly, this was a very landmark study establishing that there is no fear to combine the disease-modifying drugs, and one can or should use even a high dose of glucocorticoids to induce remission, especially when the patients are in early phase of their disease. And another study from Finland which came out, actually this started even prior to COBRA trial in 1993, but was published subsequently in 1999, Again, a combination of sulfasalazine, methotrexate, and hydroxychloroquine with prednisolone. Here, the prednisolone dose was low, was compared to monotherapy of sulfasalazine or methotrexate plus minus prednisolone. And again, this highlighted the fact that combination therapy patients achieve a good response. Even for the very first time, it reported that a good number of patients achieved remission. So the take-home message from this study was that combination of DMARD is better and not more hazardous than therapy with a single disease-modifying drug. And if it is being given for a continued or sustained period of time, then the patients continue to have a better outcome. Another landmark study which came out in early phase of 2000 was this BEST study, again from Netherlands. Here they actually divided patient to 4 groups: sequential monotherapy or a step-up combination. Patient started with initial combination therapy with prednisolone, and the 4th group receiving initial combination therapy with infliximab. And this, for the very first time, showed that patients who received combination therapy with prednisolone or infliximab, they did similar, but better than the patients who received sequential monotherapy or step-up approach to combination disease-modifying drugs. This has been highlighted here in form of the health assessment questionnaires, which improved in the combination group versus the sequential monotherapy or step-up approach, as well as the radiographic progression was much less in the combination group, both with prednisolone or with infliximab. So there was this was the sort of the outcome of this study, that there is less radiographic damage after 1 year as compared to sequential monotherapy or step-up approach as compared to the combination therapy, either with prednisolone or infliximab. So actually the concept of treat to target is not new in medicine, and many chronic diseases like diabetes or cardiovascular diseases like hypertension or ischemic heart disease are following this for many decades. However, this concept was applied to rheumatology very late. And the very first time the recommendations of an international task force came into literature in 2010. And this only happened because on one hand, we could see that many combination therapies with conventional disease modifying drugs were actually were reporting superior results. And in addition, a lot of biologic agents had come into force. By the time infliximab and etanercept had shown that even patients who had got established rheumatoid arthritis, they now show a very good response after treatment with these biologics. And also when these biologics were used earlier in the course of rheumatoid arthritis management, then the patients tend to have a good number of remission or near remissions. So based on this, this group convened together and formulated certain principles for treat to target in 2010, which were revised in 2014. In 2010, most of the recommendations were based on expert opinion and not hardcore evidence as far as literature is concerned. But by the time 2014 arrived, there were a lot of evidences available for most of the recommendations. So these were revised in 2014. So the basic principle remains of this treat to target was that treatment of rheumatoid must be based on a shared decision between patient and the rheumatologist. And the primary goal is to maximize the long-term health-related quality of life by controlling these symptoms, preventing the structural damage, normalizing the physical function so that patient is able to participate in social and work-related activities. And these could be achieved by abrogating the inflammation, which is the key to failure of therapies or key pathogenetic event which is causing damage to the joint in these patients. Also, this treatment to target can be measured by certain optimized outcomes which are available, which are reliable, and which has shown consistency in various clinical trials prior to that. So the primary target of treatment of rheumatoid arthritis, as far as treatment to target recommendations are concerned, is to achieve a state of clinical remission. And this is based on few studies, but I just taken one study where it was clearly shown that when the strategy to target remission was followed by a tight control in 126 patients versus the usual care group of patients, the patients who were given the tight control regime, they achieved remission in almost 55% of the cases as compared to 30% in the usual care. So clearly the strategy has worked. And also the DAS scores were lowered significantly early and persistently, those who had received regime as far as tight control is concerned. Why do we want to achieve remission actually? How is it going to benefit the patients? Because patients in remission, they do not show or show a very minimal radiographic damage progression. That is one thing. Other thing is that patients regain their physical function. There are less hospitalizations. There are less joint surgeries, lower mortality rates, and finally, in the long run, lower healthcare cost to the patient. The second recommendation of this international task force was to that the clinical remission should be defined as absence of signs and symptoms of significant inflammatory disease activity by reliable disease activity measurement scores. And this task force has recommended for these four: clinical disease activity index, DAS, DAS28, or simplified disease activity index. But there are catch points to all this. DAS28 remission always does not mean remission. Still, patient may have significant disability if there is only a single joint, and that is an important functional joint which is being affected. May be classified as DAS28 remission. However, patient may continue to have significant disability because of that. But more or less, most of these disease activity measures have got a linear relationship between disease activities and impairment of physical function or damage progression. So if we can lower these any of these disease activity measures, the chances are that patients will improve clinically as well as functionally also. Also, it has been recommended in one of these recommendations that remission may not be possible for all the patients. So in certain subset of patients, even low disease activity is an acceptable alternative therapeutic goal, especially those who had either a long-standing disease or who have got a comorbid conditions, which do not allow to go for an stringent control of disease activity by the use of conventional or biologic disease-modifying anti-rheumatic drugs. Also, to follow a validated composite measure of disease activity, which should include a joint assessment for assessing the patient outcome and making decisions based on that. We all know that even a persistent swollen joint count means that patient is likely to have progression of joint damage, whereas tender joints, obviously they relate to the physical function and poor health assessment outcomes. The choice of composite measures of disease activity and the target can be influenced by comorbidities or other patient-related factors or drug-related risk, and these should be taken into consideration. For example, patients having cardiovascular diseases or chronic liver disease or renal diseases, we cannot use or target their sort of remission states or low disease activity based on all the equal composite measures scores. We need to personalize these composite measures of disease activity. But once we have decided about a disease activity measure, then it should be documented regularly. If patient has got a high disease activity, then it should be as frequently as monthly. Or if patient has got low disease activity, then based on choice of rheumatologist and the patient 3 to 6 monthly. We also need to continue to monitor the structural changes and functional impairment of the patient. Now, here is a catch point. Structural changes, it's not very clear, should be done by routine radiographs or newer imaging modalities like ultrasound or MRI. Probably this, maybe future guidelines will make it much more clear when the evidences are available. But one need to keep in mind that until the desired treatment target is reached, drug therapy should be adjusted almost at least every 3 monthly. And once the desired treatment is achieved, it should be maintained for the remaining course of the disease. Here, another catch point is that we do not know when to step down the disease-modifying drugs. What should be the ideal regime? It's not very clear. And lastly, in all these decisions regarding disease activity measures, drug therapies, rheumatologists should involve the patient so that they in combination, in consensus, set the target for the patient and the strategy to reach this target. Say, suppose there is a patient who can afford, we can even try out with biologic DMARDs. But in poor patients, obviously, this drug is not to be used because of cost constraint or cannot be used. So all these considerations need to be taken into concern while setting the target. So this is the flow diagram which has been proposed by this paper. Once a patient of active RA is there, the target is set after discussion with the patient, and a therapy is adapted so that to monitor disease activity, considering the comorbidities and other patient factors. And if patient achieve remission, then this is continued, or if there is a loss of this state, then the therapy is adjusted accordingly. However, in other condition, when the patient cannot be targeted for remission, then he or she can be targeted for low disease activity, and again, patient needs to be monitored using a composite measure of disease activity every 1 to 3 months. And once patient achieves the low disease by whatever regime is being targeted, he should be maintained in that state for a long period of time. But what is the Indian scenario? What we are talking is right from the West. I'll just briefly highlight few shortcomings in our Indian perspective. This is a paper from Mumbai from Dr. V.R. Joshi group, and he reported that there is a good going lag time between the disease onset and first visit to a tertiary rheumatology center by patient with rheumatoid arthritis. And this median delay is of around 24 months. So the golden opportunity for treatment is lost, and by the time patient is reaching the rheumatologist, joints are far advanced and may be damaged. So this is the real concern for all of us, to make early diagnosis, and patients should be made aware so that they can reach the rheumatologist early. Also, there is a delay in seeking medical help in patients with rheumatoid arthritis. And as per the patients, they said that there is a delay in the referral, reaching the diagnosis and treatment initiation by the healthcare system, which is the sort of culprit in causing the delay in diagnosis. Other report has suggested that, this is from Professor Malviya's paper, that treatment of RA in India is suboptimal for most of the patients. Only 1/3 of the patients are seen by a rheumatologist, and most of the other patients are treated by all kind of practitioners, including alternative medicine practitioners as well. This is a small data which was coming from a survey during one of the APCON in 2018, and of 333 MD physicians, almost most of them felt there is a very inadequate rheumatology training at both undergraduate and postgraduate level. And most of them felt that they need a further training or sensitization in rheumatology. And this report, which came out at the bottom in Deccan Times on October 20th, clearly shows that India has got only 800 rheumatologists as against the requirement of more than 20,000. So what is the context of treat to target in India? Well, the principles and the recommendations remain the same. However, following points need to be kept in mind while deciding about treat to target approach. We need to understand that our patient should understand the disease and need for long-term therapy. The rheumatologist also need to understand the cost constraint of the patient for drugs as well as investigations and other things. Also, most of our clinics are overcrowded. So whether we can give enough time to the patient and can ask him to come for frequent follow-up visits, which probably may not be feasible for most of the rheumatologists. Whether patient has got access to healthcare system or a rheumatology center, because there are many states in this country where even not a single rheumatologist is there. Already established disease or deforming disease is there, then we have to be realistic in setting the goals or targets. We need to be much more proactive in making patients for the need of to understand the need for compliance to treatment, because it's going to be a lifelong treatment, and most of our patients tend to fall out of line and they go to the alternative medical practitioners and cause more damage to their health. Then we need to consider, because India has got a very high rate of infections and comorbidities or environmental pollution, so one need to take into consideration that also. Also, because of social reasons, personal preference, or logistics in rural background, most of the patients probably may not opt for a parenteral form of treatment and will look for something oral. And also, most of our patients do not have any kind of health insurance coverage, so we are limited by cost of drugs. But even then, I will briefly point out few landmark studies just to emphasize my point that we do not need biologics or costly treatment for treating our patients, even with treat to target approach. And for this, I'll take this help of this tier study design, where the step up from oral methotrexate to triple drug or a biologic etanercept was considered, and it was seen that combination and the etanercept performed equally well at the end of 102 weeks. So clearly, combination therapy performs as good as a biologic at a very fraction of the cost of the treatment of biologics. Also, C4 study has clearly shown, and even here also, that even monotherapy with methotrexate can achieve a good response in good number of patients. So these patients can be maintained on methotrexate alone. If somehow patients do not tolerate methotrexate or require a high dose, then these patients can be switched over to a parenteral form, especially subcutaneous form, where the bioavailability of methotrexate is high. And it has been shown that patients who were switched over from oral to parenteral form, they had a good response. Also, patients who do not respond adequately to methotrexate, they can be offered a combination of single or a combination of multiple disease-modifying anti-rheumatic drugs. And it has been reported in this particular paper that a combination of 3 drugs, methotrexate, hydroxychloroquine, and sulfasalazine, most of the patients can achieve a good response as compared to those who were on methotrexate alone and were not doing well. This is a list of various studies where a lot of biologics have been added to patients who had got inadequate response to methotrexate. But I've just highlighted one form where a combination of disease-modifying anti-rheumatic drugs could also achieve a very good response in patients who do not respond to methotrexate alone. RACAT study is again sort of a head-to-head trial of looking at patients who are inadequate responders to methotrexate, whether they should be given a combination of disease-modifying drugs or a biologic in form of etanercept. And it was seen that patients who received combination or biologic, they almost did equally well So there is no difference between a combination therapy versus a biologic added to methotrexate in patients who were inadequate responders to methotrexate. Not only clinical DAS score, but also the radiologic score were almost similar between the two groups at the end of 100 weeks. Similarly, SWIFT study has also clearly shown that patients who were inadequate responders to methotrexate, when they were given combination or they were added infliximab, they did almost similarly for 6 and 9 months. By 12 months, there was some efficacy of infliximab as compared to the conventional combination therapy. However, it was reported by this authors of this paper that probably it was due to loss of some patient in the combination group and in the infliximab group, which led to this difference. Otherwise, they felt more or less patients were doing similarly.
Because I think we have to slowly wind up.
Yeah, I'm just picking up pace. Same was true for the radiologic progression. And the TR study, as I had shown that there was no significant difference when the biologic was added versus the combination of conventional synthetic disease modifying drugs. And also there was not much difference in the radiologic progression between the two groups. This is a table which I have taken from one of the article showing that most of the time combination conventional synthetic disease modifying drugs were doing equally well as the biologics. So the summary is that there will be patients who will do very well with methotrexate monotherapy. So when we should give them a chance. Those who do not tolerate can be given a trial of subcutaneous methotrexate. And once patient has got inadequate response to methotrexate, they can be given a trial of combination disease modifying drugs or a biologic. In Indian setting, maybe a combination of conventional synthetic disease modifying drugs is much more important. So this is the slide which remains the same as has been proposed by the international task force. That when you see a patient, you identify the target for the individual patient in form of DAS 28 or whatever you wish to, and you set the target in the time frame, monitor regularly, and if patient achieve the target, fine. If no, then you keep changing the therapy sequentially or serially or additively so that you achieve the target. So with this, I will thank the people for listening to this presentation of mine. And if there are any questions, comment or suggestions, everybody is more than welcome. Thank you.
Thank you, Dr. Vikas, for a very detailed presentation and a wonderful disposition. And I'll take a couple of questions. I'll synthesize a few questions. Most of the people are interested in after how many years or months after complete remission you would like to reduce the dose of the medications. This is the common questions from 2-3 listeners.
Yeah, actually, this is a question even for me also, but nobody knows the answer actually. Maybe people who are senior enough and who has got enough experience, maybe if Professor Malviya is listening, he can better answer this. But as far as this international task force recommendations are concerned, you should maintain remission for at least 6 months before starting decreasing the drugs one by one.
Good. And rituximab being one of the cheap choices or economic choices in India as a second line biological drug. But would you consider it due to COVID epidemics, in the scenario of COVID epidemics?
If you really ask me about COVID and our practice of rheumatology, I think initially we were scared for the initial 3 months and we were actually withholding or delaying the injections. But over last 6 months, whatever experience we have gained out here in SGPGI, we are a COVID center and we have got almost more than 250 beds of COVID, and we all have done our duties in COVID ICU. And so we had enough exposure to the patients. What we realized that there is no need to cut down on any kind of immunosuppression, be it rituximab or be it even cyclophosphamide for that matter. And we have not found any significant adverse or severity of COVID or other infections in last couple of months.
Thank you very much. Thank you very much for the talk. And I think for want of time, I will move on. And if you find any other questions in the chat box, I think you can answer them. Because
thank you.
So now we'll move on to the last but not the least most interesting session. Dr. Gayatri from Pune is going to present her most challenging case. Over to you, Gayatri.
Thank you, sir. Thank you for introducing me. I would like to thank organizers for giving me this opportunity. A very good afternoon to everybody. Can we start the slides, please? Yes, so I'm going to present this case from BJ Medical College and Sassoon General Hospital, which is a government institute in Pune. So yes, we had this 18-year-old male who presented to us with loose stools, abdominal pain associated with low-grade fever of 4 weeks duration. He also had underlying cognitive dysfunction, so he was labeled as mental retardation, and he also had underlying seizure disorder for which he was put on risperidone and carbamazepine. When he came to us, he had anemia, he had anasarca in the form of ascites, and clinically he also had pleural effusion. So his labs revealed anemia with low albumin status. At this point, his urine routine was normal. Hence, because of the abdominal symptoms, his USG abdomen was done, which showed dilated bowel loops. Hence, CT abdomen was done by treating physicians. So it showed typical target sign. I have the images later. Hence, gastroenterologists were involved. He did colonoscopy and biopsy was done, which was suggestive of necrotizing enterocolitis with evidence of vasculitis. Further workup was done. The usual triple H, HIV, HBS, HCV were negative, but his CMV DNA he had more than 1 lakh copies of CMV DNA. So he was treated with ganciclovir. His loose stools and abdominal pain did improve, but his anasarca did persist. So he was further evaluated and autoimmune workup was done by gastroenterologist. His ANA was strong positive. It was 1:320 in the speckled pattern, and his ENA was positive for SMRNP. I don't have the titer. So at this time, he was labeled as necrotizing enterocolitis with ANA positivity. He was not really fulfilling the SLIC criteria. Hence, rheumatologists were involved and he was given trial of steroids. He did improve. There was improvement in hematological parameters and his serositis. Next slide, please. So this is the imaging which shows bilateral pleural effusion, which is right more than left. And as you can see on the CT abdomen, there is typical target sign, which is suggestive of enterocolitis. So next slide, please. Okay. So he was lost to follow and his steroids were stopped. But a poor man came to us with worsening of symptoms after 4 weeks. He had increased anasarca. He landed in pancytopenia. At this point, his urine routine showed 3+ albumin with 15 to 20 RBCs per high power field. His 24 hours urine for protein showed 5 grams. His complements were very low. Because he had underlying seizure disorder also, at this point, his MRI brain was done, which showed multiple white matter hyperintensities. Hence, we did go ahead with renal biopsy, which showed class 4 lupus nephritis with activity index of 7. So, of course, now we don't have any doubt about the diagnosis. So, he had neuropsychiatric manifestations with class 4 lupus nephritis. He had hematological involvement, ANA, ENA being positive, and he had low complements. So at this point, he was treated as SLE major organ with the NIH protocol. So far he has received 5 cycles of cyclophosphamide. He is doing well so far, but in between 2 cycles of cyclophosphamide were delayed because of 2 admissions for respiratory tract infections. Next slide, please. So these were his investigations. So during SLE activity, he had anemia, leukopenia, thrombocytopenia. As you can see, his creatinine was deranged. His albumin was quite low. Urine routine had 3+ albumin and numerous RBCs. However, after 3 doses of cyclophosphamide by NIH protocol, and of course with steroids, his HB, WBC count, platelet, everything improved. He had lowish albumin, but it also did improve. His urine routine was almost normal after 3 doses of cyclophosphamide. Next slide, please. Okay, so why did we have delay in the diagnosis? We had a young male who had multi-system involvement. So was CMV enterocolitis the reason, or as in multiple sclerosis, his organ involvement was in time and space, or was it a male gender? So he was not really paid attention to. His earlier presentation was anemia, serositis, his ANA and SMRNP were positive. He had CMV enterocolitis. However, later when his steroids were stopped, he had typical SLE. He had pancytopenia, serositis, very low complements, and new onset renal and neurological involvement. Next slide, please. So to summarize, we have 17 years old male who had necrotizing CMV enterocolitis, which did respond to ganciclovir. Also, later had SLE with major organ involvement, which had good response to steroids and cyclophosphamides. But in between, he had recurrent lower respiratory tract infections and admissions. So next slide, sorry. So were we dealing with some kind of primary immunodeficiency associated with SLE? So we had some features for like recurrent and atypical deep-seated infections. His complements were very low and he had lupus nephritis and glomerulonephritis. However, his age was against. His cytopenias did respond to steroids and cyclophosphamides itself, and there we did not give any IVIG, still he had a good response. Next slide. So yes, did infection precipitate SLE or SLE led to necrotizing enterocolitis? So yes, as we all know that few complement, especially the initiator complement like C1q deficiency can lead to SLE. Then there are other complement deficiencies like C2, C4 can lead to SLE, typically associated with recurrent infection. So that could be one of the reasons, or CMV itself can lead to SLE flare, or it can actually lead to formation of new onset SLE, or it can precipitate SLE in pre-lupus or in those who have just antibodies, or in those who SLE could be indolent. So these two could be the causes for his disease. Next slide, please. So why did I present this case? Because SLE enteritis is a very rare complication and we really have to look for it. The diagnosis is based typically on CT findings. It is typically steroid responsive with an overall excellent prognosis if treated earlier. However, our patient presented with necrotizing enterocolitis, which probably led to delay in the diagnosis of SLE. And necrotizing enterocolitis is immunocompetent, and even in SLE patient is not really heard of. I got very few case reports. Hence, this case warrants a discussion. There is a possible role of IVIG in a recurrent deep-seated infections in SLE, especially in complement deficiencies. Next slide. So I would like to thank the team BJ Medical College. I would like to thank Professor Dr. S.S. Angle ma'am, Head, Dr. Sanat Phatak and Dr. Prasad for their valuable inputs. Thank you.
Thank you, Dr. Gayatri, for a very, very interesting and challenging case. I think I have a couple of queries to you.
Yes.
Did the boy was found to have mental retardation and seizures since childhood, or is it of a recent onset?
So he actually was told to have, he was 17 years and his mother told us that since 12 years of age, he actually had mental retardation because they come from lower socioeconomic background. He was not really paid attention to, I think, but that's what his mother told us.
So that makes it a less likely cause of due to lupus. Would you agree with that? Would you attribute this?
Sir, it could be.
Yeah.
Yes, sir. He could be having mental retardation, but the seizures probably were due to SLE.
And do you think any of the drugs could have contributed to his developing lupus? Risperidone.
So far,
is there any data on risperidone and carbamazepine? Do you hear me?
Carbamazepine can. Oh yeah, I can hear you. Hello, sir.
Yeah,
carbamazepine can lead to, but this kind of infection, necrotizing enterocolitis, usually drug-induced lupus will not have so much of renal involvement and neurological involvement. Yes. So I don't think the drugs were the culprit.
That's a good point. Did the neurological symptoms improve?
His seizures did improve. His mental retardation is not obviously has improved, but his seizures, he has not had seizures. He's on anti-epileptics, but he was on anti-epileptics before also. But after our NIH protocol, he did not have seizures further.
Yeah. There is one question from Dr. Durvesh. Why was CMV DNA done? What was the suspicion Where was the suspicion?
Sorry, sir.
And there was a question from Dr. Durvesh. He was questioning why was CMV DNA done?
Okay.
Why did the gastroenterologist suspect?
Actually, he had necrotizing enterocolitis, and that's a very it's an organ-threatening thing, obviously. So the initial workup was done by a treating physician's team and gastroenterologist, and they feel that CMV is the leading cause, one of the leading causes in necrotizing enterocolitis, especially associated with vasculitis. So probably, and he had low albumin, he had loose stools, so he had a lot of gastroenterological involvement clinically as well. That's why CMV was done.
Good. And same, one more question. Did you do a pleural or ascitic fluid tap? What's the question?
Ascitic fluid was sterile. Pleural fluid was sterile. The workup for Cox was also done. It was just recent onset, but still everything was done. His ADA was normal, and but pleural fluid was exudative, but it did respond to steroids itself. He was given broad spectrum antibiotics, but all the workup for Cox, including MON2, was negative.
Yeah. So it's a wonderful case, and this is the usual case, a complex lupus patients we see in our clinic.
Yes,
I think he is a male known to have seizure disorders and mental retardation, presenting with CMV enterocolitis and probably smoldering lupus at that time. And it was not probably the treatment of enterocolitis took precedence over diagnosis of lupus at that time.
Yes,
and probably the CMV infection might have precipitated a lupus flare or aggravated the underlying smoldering lupus. So he has responded very well to cyclophosphamide therapy. So it's not a typical case, but this kind of patients keeps our specialty interesting.
Yes, sir.
And keeps us always on the toe and forces us to remain physicians.
Yes, sir. That's the thing.
Thank you very much, Dr. Gayatri, for the wonderful talk and the presentation.
Thank you, sir.
And my sincere thanks to all the organizers for making this WRF forum a fantastic first day today. And I hand over the mic to Dr. Ajit, who is the organizing secretary, for his vote of thanks.
Thank you, sir. Thank you very much. A very good afternoon to all. We were very eagerly looking forward to welcome you all to Pune, with all set for WRF Summit 2020 on March 28th. The unprecedented COVID pandemic had something else in store. However, the show has to go on and learning must continue. And indeed, today it was a very fantastic session one. And I have to thank many for this. First of all, I would like to thank all those delegates, almost more than 1,000 delegates who have registered for today's session, because for making our efforts worthwhile. The program is also running on another platform known as Rheumatology. It is an initiative of Sancheti Hospital, and I would like to thank Mr. Rahul Chobe and Dr. Ashok Sham for the support. Thank you, Professor Chris Edwards and Professor Vikas Agarwal for those fantastic talks, and all the young dynamic rheumatologists who have shared their experiences, and our moderators, Dr. Dharmanand, Dr. Raj Kiran, and Dr. Meha for the engrossing discussions we had today. We are grateful to our patrons, Dr. V.R. Joshi and Dr. Mahendra Nath, for inspiring and motivating us. I would like to thank Dr. Arvind Chopra, who is our organizing chairman, for being a guiding force and for all the support from him. I thank the office bearers of MRA, Professor Shashikala Sangle, HOD Medicine, Department of Medicine at BJ Medical College, Dr. Parag Sancheti, Chairman, Sancheti Hospital, PASIG, and Focus Arthritis Foundation for associating with us. Thank you to all my colleague rheumatologists from Pune, Mumbai, and rest of Maharashtra for the good wishes and all the help you have provided. I have to thank Scientific Chair Dr. Vinod Ravindran, Dr. Mohit Goel, Dr. Akshat Pandey for their dedication and the meticulous planning. I thank Dr. Indrajit Agarwal, Dr. Bimlesh Pandey for the initiative and the insights without whom the program would not have been possible, and all those who have assisted us in organizing this event. Finally, I thank our knowledge partners, IPCA Laboratories, for their help and tech support, especially Mr. Amit and Mr. Viraj. Before I conclude, there are two announcements I have to make. The first one is for all the delegates who have been listening from the platform for whatever website, there is a tab that has appeared after 12:30 that is for downloading the e-certificates, and this tab is only available for 1 day, so I would request all to download the e-certificates today itself. And please join us for the day 2 of WRF webinar in 2 weeks time on December 20. Thank you. Namaste.
We are offline now.
Yeah, perfect.
Very well done. Very well done, Ajit.